Hello and welcome to a panel addressing stigma to ensure equitable and accessible TB care in India. TB does not discriminate. It can happen to anybody. TB-related stigma, however, discriminates against affected individuals and their families. The challenge is that even today, we dominantly address only the clinical determinants of TB in India. We ignore or half-heartedly acknowledge the stigma that affects individual health and their access to TB care. We think stigma can be addressed through just simple awareness and information. With this panel, we want to try and change this thinking. We will focus on the affected individual's experience of TB-related stigma, why addressing stigma is critical, and how we can address TB-related stigma to make TB care in India accessible and equitable. Let's have a look at our panelists. Our first panelist, Devashri Lokhande, is an XDR TB survivor and SATB fellow who is a vocal advocate on national and international stage. Her presentation sets the stage by highlighting TB survivors' experience of TB-related stigma and how this stigma impacts them. Next up, we have Dr. Karuna Sagili, a public health professional, Deputy Director, Knowledge Management and Research, ACSM NTSU at the Union Southeast Asia Office. She will present on why addressing stigma is critical to India's TB response. Then we have Dr. Ruwanti Nathavitharana, who is an Assistant Professor of Medicine at Harvard Medical School and the Chair of TB Proof and Advocacy Organization. She will present on designing interventions to end TB stigma, drawing on the South African experiences of TB stigma. Finally, we have Ashna Ashesh, a public health professional, lawyer, MDR TB survivor who advocates for TB affected individuals at the national level and whose work is informed by a rights-based approach to TB care. Her presentation will examine the ways in which law can be used to mitigate TB-related stigma in India. So let's get started.
Hello everyone, I'm Devashri Lokhande, an XDR TB survivor and a fellow with Survivors Against TB India. And I'm very happy to be speaking at the India TB Summit on this panel for addressing stigma for TB care in India. Stigma matters. I'm here to talk about understanding stigma, its impact, and learning from narratives of TB patients. So what exactly do survivor stories tell us? My journey with TB did not end with treatment end. For the sole reason that I wanted to effect a revolution in fighting the stigma surrounding TB. I had stayed quiet for too long, not anymore. So let's try to cover the intersectionality of stigma and TB. Here we are mainly going to try to study the sources of stigma and how exactly does it impact a TB patient, their life, their care, and life after care and their experience. So, let's talk about understanding social stigma. Social stigma is a stigma born out of the society. You're looking at it from the point of view of the case study of Tejal, who is a pulmonary XDR TB survivor. She faced stigma from her neighbors and the community. She was also stigmatized by the hospital staff until her doctor intervened. Her family too faced discrimination. Moreover, she was asked to hide her illness even after treatment end, just so as not to affect her sister's marriage prospects. This affected her mental health, this affected her self-image, and TB stigma affects families and patients even after treatment end. Let's understand social stigma from the point of view of Mansi's case study. She is also a pulmonary XDR TB survivor. She faced stigma from the community, specifically from the older generation of people. They would advise her friends against visiting her out of a fear of infection. And as a positive, heartwarming change, Her friends would advocate for her and stand up for her, making those stigmatizing her understand that with the right precautions, one needed fear proximity with TB patients. This episode highlights the importance and the need for awareness and peer support to fight stigma. So, what are the key learnings from these two case studies that we learned about social stigma? Social stigma is primarily born out of a fear of infection. The myth surrounding TB, like TB is genetic or it is incurable. These cause great harm to the image of TB, to the mental health of TB patients. There exists a cruel tendency to lay blame on the patient and the family. Poor awareness of TB feeds the myths and the stigma. And more importantly, stigma is gendered. It affects women and those of non-binary genders disproportionately. Let's study stigma from the point of view of a workplace or healthcare setting through the case study of Seher, who is a drug-sensitive TB survivor. She is educated and could afford private sector care. She faced stigma right at the first point of care from the doctor whom she had approached to seek care, who outright denied her treatment. The doctor somehow implied that it was her fault that she got TB. This stigma also reflects the social association of TB with class, illiteracy, and poverty. Moreover, she was afraid to share her diagnosis at her workplace. She felt that as a woman in a corporate sector job, when you try to show infirmities, you don't want to really be portraying yourself as a victim. This is because TB is stigmatized due to its association with poverty and social class. Let's look at stigma in a workplace or healthcare setting from the point of view of Diptendu's case study of an MDR TB survivor. He is an educationist by profession and a scientist by training. He faced stigma from his doctor who would refuse to enter his room, treating him like an untouchable. He faced stigma from his PhD supervisor who refused to work with him. These behaviors tended to affect his mental health, his self-image, and treating the patient as a culprit will only lead to a cycle of depression and self-blame. Let's look at stigma in a workplace or healthcare setting from the point of view of Divya. Her case study is she is a nursing officer at the AIMS hospital. She defeated TB thrice in an 11-year career and faced severe stigma causing distress and mental trauma. Her colleagues, fellow healthcare personnel, refused to be in proximity with her. This stigma born out of a fear of infection and desensitized community behavior. So what do we learn from these three case studies? The health system can perpetuate stigma. Health workers need stigma training and information and awareness. The focus should be shifted from patient monitoring to treatment with empathy. Workplaces strongly need stigma mitigation programs. We need to create a holistic, sensitive program for patients to freely report or access help when stigmatized. They should not feel that they are fighting this battle alone and that there is a support system in place where they are heard and they are guided forward. Lastly, let's talk about internalized stigma through the case study of Dipti, who is an MDR-TB survivor and a patient advocate. Dipti fought a long battle with MDR-TB for 6 years, which included 2 surgeries. She faced internalized stigma after insensitive remarks and behavior of relatives and the community. She drastically self-stigmatized after a change in appearance when on anti-TB treatment. This highlights the need for affected individuals who need information on stigma mitigation. So what are the learnings of internalized stigma from this case study? That internalized stigma impacts a patient's will to complete treatment. It greatly determines a patient's experience and the mental and emotional trauma. Stigma created as a result from society, healthcare settings, media portrayal campaigns. These distort a patient's self-definition and causes them to self-blame and self-hate. Self-stigma is a learned behavior, but it is not impossible to mitigate and overcome it. And it can be done via sensitization, counseling, peer support, and awareness. So, what are the important lessons that we need to carry forward? Stigma is an imbibed response to created from a system which has turned a blind eye to TB. The fear of discrimination forces people to delay seeking care, leading to greater infection spread. Communication and awareness programs around TB stigma are all top down. And we need to realize that science alone cannot defeat TB. There needs to be proactive communication and sensitization programs. So, what is the way ahead? Stigma needs a comprehensive strategy. Legal and punitive solutions need to be in place for a patient to openly approach and use. There needs to be workplace and healthcare interventions. Myths and misconceptions must be addressed and destroyed from the root. Patient education is a must. We cannot eliminate TB without ending stigma. TB is curable, stigma too. Thank you.
I'm glad to be part of this panel to discuss about TB stigma in India. So we are discussing about why is it important to address stigma in India's TB response. Being a medical condition, TB is also known as a social disease. India is home for 2.6 million estimated people with TB, along with being a home for people with different languages and caste systems, cultural traditions, beliefs and traditions, and various ethnic groups. TB is disproportionately affecting poor people, especially the marginalized and vulnerable communities in India who already face inequalities and inequities due to various social structures. The various social outcomes of TB include stigma and discrimination as a major part. Stigma contributes to reduced marriage prospects, isolation, branding, dropping out of schools, leading to depression, illness, loneliness, poverty, and loss of employment, and several other consequential things that are linked together. The root cause of stigma is fear. Fear of infection, fear of death, fear of financial burden, and fear of social isolation. These fears are generally not addressed by the current means of knowledge that's being disseminated. There are several myths that are part of this knowledge or the current prevailing knowledge around it. There are myths that the TB occurs from God. It's due to people's sins, that gods are not happy with us. There are existing social structures which continue to sustain this stigma and these myths because of cultural beliefs that are entangled with the caste systems where stigma is also part of it. The current knowledge of TB that is being shared with the people also quite medicalized. We do not address the social aspects of TB in the knowledge that is being disseminated. So this often doesn't help in addressing the fears and the myths in the community. For example, as we look at various literature that is already there, Union has been working on this knowledge attitude practice surveys over the period of last decade. We have done 3 different surveys. What we understood is that the stigmatizing attitudes and discriminating attitudes are very high among the general population. So why is it? So why is that the correct knowledge of TB is it not associated? Why, when people have correct knowledge, do they still stigmatize? When we try to look at it, what we found was that stigmatizing attitudes were independent of correct knowledge of TB. Because it's not just the knowledge that they have, but it is also the various aspects of the social aspects that contribute to your attitudes, that inform your attitudes, that inform your discriminatory practices. And this, in fact, have an effect on the people with TB in various aspects, like leading to depression, low self-esteem, self-isolation, hiding the history of TB because they fear that they may not get married because if people will get to know that they have TB, they will fear to losing job. So these things are kept in hiding. So this consensual framework gives us a very important image of why we need to address stigma in India. This is something like this iceberg, where a major part of is hidden. What we see outside is only a little bit, but what is hidden inside is not seen, and hence we perceive that it is not there. Social aspects of TB are largely like this. Why should I address TB why should I address stigma for TB services? Does it affect TB services? Yes, of course. How does it affect? It is contributes in delay in seeking help. It contributes in delay in diagnosis. Apart from the technical aspects of diagnosis, it is the people who need to go and seek these services that may not want to go because of the existing stigma and discrimination. There are reduced treatment adherence that happens. That is seeking in private sector because often government public sector hospitals are the ones which many people access, and they fear for confidentiality and they would prefer private sector, which also adds on to the catastrophic cost due to treatment. So there are various threads attached to this. This is not as simple as we think. And this is again, we have got reconfirmations about this while we did the systematic review and meta synthesis of qualitative research on TB. This is a recent review. We are just in process of submission. But what we understand from this synthesis is that the cultural aspects play a key role in TB treatment adherence, and also various contributions like the stigma, TB associated stigma is very significant part of treatment adherence. So how far are we? What are we doing? What is being done? Is it enough? Yes, we have done a lot. The civil society and TB survivor advocates and many other stakeholders have been advocating for addressing the various aspects of social aspects like stigma and discrimination. And recently, the national program has taken up a very strong stand. They have started TB champions training, in which the TB survivors are being trained as champions, and they are being supporting peers in understanding TB and in completing their treatment, counseling, advocacy for various aspects. We also have come up with a strategy to end stigma and discrimination. This document was prepared with the partners and the program, and this was launched last year in the TB Day. We have community engagement guidance that has been developed, and right now across the country, various people are being trained on this community guidance, how to engage communities, how to address these aspects of stigma and other social aspects. We also have self-learning toolkits that have been launched by the National TB Program to become TB champions, how the TB survivors can become champions and advocate for this. This is a great move. And we are progressing, yes. We also have another great initiative that has come up, which is the National Technical Support Unit, which was established specifically for advocacy, communication, and social mobilization. Now, this was started with a objective to create a Jan Andolan. What is a Jan Andolan? Jan Andolan is a people's movement. It is not the National TB Program. It is not key stakeholders or the civil society. It's only few organizations or few individuals. It is of everyone. It's a people's movement. Unless everyone in India knows about TB, the approach that should come from bottom up and not from top to bottom. So unless everyone talks about TB, we cannot destigmatize TB. So to have a TB Mukt Bharat, which is now the campaign that is running, it is called the TB Mukt Bharat Abhiyan. And unless we have this campaign coming from the bottom up, it's very hard for us to move forward on this. So yes, as I said earlier, we are making progress, and we have to continue to evaluate ourselves. And to have a TB Mukt Bharat, we need to have a TB stigma Mukt Bharat. That is something which we need to work towards it, and I'm sure we will do it. Thank you.
Hi everyone, my name is Ravandi Nathavitharana. I am an infectious disease doctor and assistant professor of medicine at Harvard Medical School and the chair of TB Proof. I'm really delighted to be here today to talk about intervention design to end TB stigma. So as part of our panel, we've been hearing a little bit about what stigma is, and I wanted just to reiterate about stigma being differences, starting with differences being linked to negative stereotypes, which lead to a separation of us versus them, and this leading to a loss of status for those people who are ascribed to be different. We know that stigma is a barrier to high quality TB care delivery, but what we don't know is how best to target stigma reduction interventions and how best to design and implement them. I wanted to showcase this piece of art by Paulina Sinyatkina, a Russian TB survivor who I think work sort of encapsulates these components of stigma that are experienced in terms of both enacted, internal, as well as anticipated stigma. So just to sort of go a step back and sort of discuss a conceptual framework for stigma, we have drivers of stigma, which may include aspects such as blame, facilitators of stigma, which may relate to how TB clinics or hospitals are set up with TB patients being segregated, for example, or how messaging sort of focuses on negative aspects of sort of risk and people feeling like they're risky behavior, whether it's related to substance use or dual conditions such as HIV that has led them to get TB. And this then leads to manifestations of stigma. And the three that I'm going to focus on are anticipated stigma, internal stigma, and enacted stigma. And I'm going to give you a couple of examples of that. So anticipated stigma is where there's a worry about what may happen to them. So for example, a fear of gossip or a fear of other repercussions across a variety of spheres in their lives. Internal stigma, which may be driven by blame, for example, leads to a negative self-perception and bad feelings about themselves. Enacted stigma may be in the community, for example, loss of respect or loss of standing, or in the work arena with the loss of job, for example. And these types of stigma can impact TB care across the cascade. So they can impact a variety of cascade outcomes. So care seeking, treatment initiation, adherence, retention, for example, not comprehensive. We conducted a scoping review where we looked at, we initially screened 1,400 abstracts and it basically extracted data from 9 studies. What you can see from the range of ages, so these studies sort of go back from 2003, and then the most recent one in this review was from 2019. The studies came from a variety of countries, from South American countries such as Peru and El Salvador and Nicaragua in Central America, as well as African countries such as South Africa, Nigeria, Ethiopia, Asian countries such as Taiwan. And we broke these down into different types of interventions. For example, a lot of them focused on psychosocial support groups, other support groups, so either led by, for example, in Peru, led by a psychiatrist and nurse, versus TB clubs led by TB survivors. Other interventions included educational workshops or educational videos. Another intervention included participatory theatre with health workers. And these targeted different domains of stigma at largely the individual, sometimes the community level, and sometimes the interpersonal level where households or other contexts of someone with TB were involved. But you'll notice that none of them targeted the policy level, which is a gap in intervention design. And you can see that with only 9 studies, there really is limited data on this topic. So few studies actually differentiated the interventions by stigma domain, and the definitions of stigma varied. There's wide heterogeneity, a lot of variability in the approaches used to measure stigma within the interventions and how these were reported, and implementation outcomes such as how was this intervention delivered, who delivered it, what was the fidelity, what was the access, what was the penetration, for example, were sparsely reported. So this really led us to conclude there's really a need for targeted and context-specific interventions to address the different domains of stigma at different stages of the cascade, including at the policy level. So we did a mixed method study in South Africa, and this was led by TB survivors working as peer research assistants, and they were conducting community-based stigma assessments using an adapted Stop TB partnership questionnaire, as well as in-depth interviews in 2 regions, an urban region Khayelitsha and a rural region, Hammanskraal in South Africa. And the participants were people who had had more than one episode of TB or caregivers of someone, including children who had had TB, and the project is called Use My Voice to End TB. So how we broke this down, and so I'm going to show you some of the preliminary results for the surveys rather than the qualitative interviews. And we broke this down across the stages of the cascade, so care seeking, diagnosis, treatment initiation, and treatment completion. And what you can see is there were high levels of internal stigma and anticipated stigma in people who had TB, and much higher levels of internal stigma for the caregivers at this sort of stage between care seeking and diagnosis. Again, between diagnosis and treatment initiation, fairly high levels, over 10% of internal stigma, almost 10% for anticipated stigma. Again, higher levels for internal stigma expressed by the caregivers. And then as you go to treatment completion, these rates go down, but still consequential in terms of internal anticipated stigma, not much enacted stigma, the proportions were much lower, but still very high rates of internal stigma expressed by caregivers. And so and then two of the questions that came up that were asked in the survey that we thought we could sort of analyze in terms of the gender response to stigma. One of the statements was, I probably got TB because I smoke, drink, or do other careless things. And you can see that a higher proportion of males, 47%, agreed compared to 16% of females. Another statement in the survey was, I've lost respect in the community because I had TB, which is around their internal stigma and also potentially around anticipation of stigma or enacted stigma. And in this situation, for this question, 13% of males agree compared to 58% of females. So you can see that there are differences in how stigma manifests across different genders. An example from the Indian context was a study done in Pondicherry where they did in-depth interviews and focus groups with people living with TB, household members and healthcare workers, which showed very high variability in TB knowledge and high levels of anticipated stigma. One of the quotes was, people listen more to what actors say, which is why I chose this figure. And so participants from this study supported interventions such as celebrity advocacy and school-based programming. So what you can see is that we can use these types of contextual data to try to design interventions that are acceptable, feasible, and then hopefully effective in those communities and in those regional or district settings. So we attempted to, as part of our work, try to put this into a framework where we thought about what were the drivers of stigma, such as blame, misunderstanding, prejudice, lack of awareness, and fear of infection, and then targeting the manifestations, so internal, anticipated, or enacted stigma, and to think about breaking these interventions down at the different levels, so individual levels, such as skills building and coping workshops, coping mechanisms, interpersonal and individual could be incorporated with support groups. Community level could be advocacy campaigns or engaging with people in households affected by TB, skills building workshops or informational campaigns. And then at the policy level, this is important in terms of laws, policy language, and programmatic documents. So this was just a sort of a snapshot of the way one might approach designing and implementing stigma interventions, and look forward to discussing more. Really wanted to thank our amazing team in South Africa, partners of TB Proof, funded by the Stop TB Partnership, and our research collaborators are at Stellenbosch University. This is our community health workers in Hammanskraal. Thank you very much. Look forward to questions.
Hello, I'm Ashna Ashish, an MDR TB survivor, a lawyer, and a public health professional. And I'm here on this panel on addressing stigma to ensure equitable and accessible TB care in India to talk to you about what are the legal resolutions to stigma in TB. So just a quick background before we get into this. TB remains a highly stigmatized disease in India as elsewhere, and TB-affected individuals face stigma and discrimination in workplaces, communities, families, and even healthcare settings. When we try to understand the impact of the stigma, we have to look at it in terms of two things. One is the human cost, and the second is the public health cost. The human cost is that stigma can cause TB-affected individuals to be isolated and alienated from community and loved ones. And this kind of isolation and loneliness often leads to feelings of guilt, depression, and anxiety in the affected individual. It also makes it difficult for people to then admit to having TB or seek care for it, or to declare that they are TB affected. And often what happens is that people may not even seek treatment for the fear of being stigmatized, because the fear creates that kind of environment for them. What happens then is that left untreated, TB can spread in the community, and this is where it then threatens our public health goal of eliminating TB from India by 2025. There is no eliminating TB unless we address TB-related stigma, and yet stigma persists. Why? So we have to understand that what's happening now in terms of addressing stigma suffers from a few limitations. And broadly, in terms of an overview, this involves a failure to recognize that stigma is also at an institutional level, in workplaces, in healthcare settings, in educational institutions. There's also a failure to recognize TB-related stigma as a rights violation and a failure to provide remedies for discrimination against TB-affected persons. Now, why legal resolutions to stigma? What would that accomplish, right? So public health legislations and accompanying policy can bring about a shift in public perception. There's a certain value signaling that something like the law does, which says that certain things are okay and certain things are not, or are inhumane or unethical or illegal. It also helps to change discriminatory practice in private and public institutions. It provides remedies to address effects of stigma, and it protects the rights of the vulnerable. And we've seen an example of this in HIV, where the anti-discrimination legislation for people living with HIV has sort of succeeded to some measure, at least in normatively recognizing all of this, and is gradually being implemented. TB can learn a lot from the lessons of HIV, whether it's the persons living with HIV who have organized and advocated for changes, whether it's lawyers and civil society that came together to work with PLHIVs to bring about this anti-discrimination legislation. So what should the aim of these legal resolutions in TB be? There are two things. One is a preventive aspect, which is to prevent stigma and discrimination. So the legislation needs to outlaw stigma and discrimination and certify it as illegal. The other is a curative aspect, which is to address the effects of stigma and discrimination. So if as a TB affected individual, I'm discriminated against because of my illness, I should have some recourse. I should have some grievance redressal mechanism where this can be addressed, right? What are the possible legal resolutions? Now, on legislation specifically for TB affected persons, along the lines of HIV anti-discrimination legislation, along with accompanying stigma mitigation policies with workplaces and resident welfare associations and healthcare settings sort of mirroring this legislation to ensure its effective implementation. Now let's have a look at what should the legislation do. To begin with, it should be horizontally applicable to public and private institutions as well as individuals. What this means is that if, as a TB affected individual, I am discriminated against because of my illness by the state or a private organization or an individual, I should have a recourse for this rights violation. The second thing that it needs to do is make stigma and discrimination a punishable offense. And it also needs to ensure that because somebody has TB, solely for that reason, they are not denied access to safe housing, an opportunity at employment or education, or access to healthcare, or entry into any kind of establishment, or denied services or goods. A couple of other things that this legislation needs to focus on is providing for a grievance redressal mechanism and detailing its workings, and providing for the details of administration of this legislation. Now, what do the accompanying policies in this have to look at? So let's take the example of workplace and healthcare. Workplace policies need to ensure an inclusive, supportive environment for TB-affected employees, a complaints mechanism to remedy discrimination or stigma, and in the healthcare setting, because here you go with the expectation of care. This is the last place where you expect stigma or discrimination. Even then, it does sadly exist. So we need policies here as well. And what they need to do is for that stigma-free, dignified, high-quality care. Also provide a complaints mechanism to address stigma in such settings, and penalty for health providers that stigmatize or discriminate against TB-affected individuals. Now, all of this would be incomplete unless you have a public awareness about these legal resolutions, because it's just a law on paper until people, not just the people enforcing it, but also the people it applies to, are aware about it. And that is key to successful implementation, creating that awareness about various things. And this can be done through national and regional governments to actively create public awareness on the issues using multilingual campaigns that focus on the rights of TB affected individuals, the legal penalties for stigma and discrimination, as well as the legal remedies against stigma and discrimination. Stigma makes it difficult for people to live and easier for TB to thrive. To address it, we need every tool we have in our box. And one of the most critical tools, though not the only tool, but still an important one, is legal resolution. We need the strong arm of the law to weed out the pernicious stigma attached to TB. Because without a stigma-free India, there is no TB-free India. Thank you.
Thank you for joining us today for this insightful and critical session. Through our panel, we just saw how TB-related stigma is a threat to the health of the individual and the society as whole. These presentations offer some crucial learnings that TB stigma puts a dent in India's public health goal of TB elimination by impacting willingness to seek care and complete treatment, that our health system and policy makers suffer from a lack of understanding about stigma. It is crucial to understand the multiple aspects of stigma and use multiple approaches from community-based advocacy to the law to mitigate TB-related stigma. TB care has to be stigma-free to be truly accessible and equitable. There is no ending TB without ending TB-related stigma. Thank you for joining us today.
Hello. Thank you so much for those wonderful presentations. Now we're just going to dive into a few questions. My first question is to Dr. Sagile. So we've of course made progress in the sense that we're talking more about TB-related stigma both in the government and in public discourse now. But my question is, why is there still this sort of lag in implementation of stigma mitigation, be it in the public sector or the private sector? If you take the example of COVID, it started out with a lot of stigma, but the way we tackled that was entirely different. But we didn't see that kind of urgency in TB, even though TB has been around for centuries. So what are the challenges in implementing stigma mitigation on the ground level in TB care?
Thank you, Ashna, for having me, and it's a great session. I am really impressed with all the presentations, especially bringing the highlight on the legal aspect as well. So your question is a very important question. Why are we lagging? Let me put a little context here. As you said, TB is it's an ancient disease. It's been there for centuries, right? So sometimes when something is lingering around and we can still live with it, we tend to take it a little less serious. I mean, in the current context, in the comparison of COVID, if you see, COVID is a pandemic. It's a pandemic that happened after a century, and then suddenly, when people were happily living, they had their routine business, and this comes up, and there are a lot of resources. Right now, when we started TB response, maybe around 100 years ago, the amount of science and interventions that we had were less. But in the context of COVID, we are in a epic stage of our science and research, and it's been a very great push that we got, a lot of resources. So comparing those two does make sense, but sometimes I think we need to look them at as two different buckets as well, because the response is like that. For example, let me take the TB program. If you see how the national TB programs have been designed, they have been designed
for a medical intervention. The TB has been always addressed as a medical problem. Though we know that, though there is research that's established that TB is a social disease with a lot of the social aspects involved, but our programs are medical programs. They are designed with the medical knowledge to be disseminated. They're designed the medical issues to be addressed, because the large belief is that if it is treated, everything goes well. We don't have to do other things because people can handle them themselves. Once I was having a discussion with a very renowned epidemiologist, and I was presenting the social aspects of TB, and we were having a kind of discussion. So I respect him a lot, but what he said was, "Oh, these things all are. It is all just on the side. If you treat the people, they'll be fine. They can just go ahead. So don't focus too much on social aspects, but look more on the medical aspects." So though I was taken aback, I thought this is largely what people or the programs are looking at. So in India recently, as I shared in my presentation, the gears are shifting. There's a slow paradigm shift that is happening, and thanks to all of you and many other advocates who have been talking across the country on this aspect, and the interventions like the TB champions, the interventions where people are bringing this issue of TB stigma on the front is very important. Acknowledgement from the largest or the highest authorities that there is stigma is also a very important breakthrough for us to move forward. Did I address your question, Ashna?
Yeah. Thank you so much, Dr. Sagili. We're going to come back to you, but we have a question coming in
Sure.
for Debashri, so I'm just going to toggle for a minute. Debashri, I mean, you're somebody who's had the lived experience of being a woman with TB, and you've advocated for TB-affected individuals. In both through the lens of your lived experience and in your work, how have you seen stigma affecting women differently? If you could just speak to that. All right, I think we're facing some technical issues with Debashri. So, Debashri, can you hear us? All right, we'll just circle back to her. Dr. Sagili, I'm going to come back to you meanwhile. When we look at our healthcare settings, we notice that even there tends to be stigma from providers or healthcare workers. How do we address stigma at the healthcare level? Specifically, what do we do to drive change in provider behaviors and the delivery of care in a way that affected individuals aren't stigmatized? Because even in our public health organization, let's say in our clinic setups, where you have these cough zones and you're triaging a patient. Now, while
Yeah.
logistically you can understand that, it can often be stigmatizing to sort of round up a bunch of people and put them in one corner. So, how do we address TB-related stigma in healthcare settings?
In healthcare sex. So this is again a very important question. As I said earlier, our healthcare systems are not exactly equipped to handle social aspects of this. So we are only looking at, okay, we have outpatient, we have people up there standing. If you go to any district hospital, you will see at least 200 to 300 people standing in the OP. Right. So if you have people with active TB who have not yet been started on treatment and they're coughing, so it is going to pose a risk for others. So as an airborne infection control, we need to triage the people with symptoms so that they are fast tracked for their diagnosis as well, consultation, at the same time for infection prevention control. So we need to really be able to understand the medical importance of this as well, because we don't want to put other people who came for other risk factors, like say people with diabetes, people with other issues are also in the OP waiting. So we need to also protect them. So that's an as a step to prevent the airborne infection. At the same time, when you triage, you are also giving importance to this people with symptoms, so that we get them quickly tested, so that we can start the treatment quickly. As we know that once the treatment is started, within a month they are non-infectious. They do not spread the infection anymore. This is how the bacteria works, right? So we need to have this understanding. But at the same time, as you are saying, this could kind of cause some discrimination, but it also depends a lot of on the public health messaging that can be played at the hospitals. Say for example, we are trying to work around some messaging. How do we help people to understand that this is this situation, or this the need for triaging is important? In COVID, we have seen when people have the symptoms, when it was quarantine was put, people, though initially there was a little bit of stigma, but people quickly started understanding because the scale was large. It was everywhere people were getting infected, everywhere people had to be quarantined, so they understood the importance. So I think we need to also treat our people as intelligent people. They are able to understand, and when given the right information, they will understand the situation ki yes, quarantine is required. So this is, if this is quarantine required for people with TB infection, we should do it. But do they know that? That is the point. So if we know, give the right information at the in a right way, then I think we can prevent stigma.
And
Most of the
what about,
yeah,
sorry, please go on.
yeah, most of the informations that are displayed or that are disseminated are often medical information, right? So we are only talking about if you have 2 weeks of cough, then you may have TB, you go get tested. But people maybe don't want to go because of the fear inside, like I was talking in my presentation. So how do we address this fear? Our current messaging does not address these fear aspects. Though we say TB is curable, you, if you understand from a life, TB is curable, so ठीक है, why should I fear or why should I worry about it? So the seriousness sometimes doesn't come. They do not know. An average Indian today will not know that in India around 1400 people die of TB every day. Do they know this? Do they know the seriousness of the disease? They don't know. So how do we help people to get serious, take TB as a serious infection, as a serious disease that needs to be addressed? When it comes to COVID, the moment people have the symptoms or having some suffocation, they rush to the hospital. Why? Because they know how serious it can be. We have seen with our own eyes here in Delhi how people have suffered and how many people died. So people understand the seriousness. But in TB, we are not able to get that level of seriousness because sometimes our messaging is taken in a lighter way. At the same time, sometimes messaging goes wrong and then it becomes stigmatizing as well.
Thank you so much. Debashri, do we have you back? Can you hear us?
Yeah, could you actually
Hi.
repeat the question? I missed
Yeah,
what
yeah,
you
sure,
asked.
sure.
Sorry.
So I have a couple of questions for you. One, I'm just going to take off from the health provider context. As somebody who has survived TB and works for TB affected individuals, what do you think we need to do in terms of sensitizing health providers? Do you think there's a need for providing trainings on providing stigma-free care, or sensitizing our health workers, our doctors, our nurses? From a survivor perspective, what do you think needs to happen in the healthcare system to help mitigate stigma in TB?
Okay. As a TB survivor, what I felt and what even Dr. Karna was saying right now was so relevant, that the TB care, like it should start from top, it should go from bottom to top while fighting stigma, which is right from stigma mitigation measures should be focused on the patient instead of, okay, we do have provisions in policies, but who checks what application, what measures are there where the patient feels that they can directly approach a, a systemic center for counseling or for help. So what I feel is empowering the patient via counseling. So you can't just put the burden on the patient, right? It should be the immediate caregivers of the patient, or the immediate society, or the neighbors, or the community, where if you counsel, if you raise awareness, that is how you are removing the fear, or removing the stigma, or the taboo, or the silence which is around TB. Like right now, what is there? Like how doctor was saying that for COVID, how did we were able to adapt to COVID and the setting of it in our society. This did not happen with TB. Why? Because of this image of TB, that this is should be hidden. It should be stigmatized. It's a taboo subject. You should keep silent and forget it and keep it away. And people should take medicines at night, hidden out of fear of being abandoned by people. So this is where, to break the silence, you have to have that the empowering, the counseling, the care system for the patient where they can freely access help without feeling that, oh my god, I have TB now, despite knowing that it is curable. Just, out of the mental burden of fighting all these stereotypes of, TB means malnutrition, putting the blame on the patient. So these are things which I really feel that for empowering the patient, you have to have a care system in place. You have to have counseling for the patient, for the immediate caregivers, for the community, or whenever they feel that someone is not standing up for them. So there should be a place. Like how Ashna was saying that workplace policies. So these are so important because they are eventually empowering the patient to feel that, okay, I am able to deal with whatever comes my way. And so most of the patient, there's also the gender related issues where there is no gender specific policy provisions for overcoming stigma, for mitigating it, and for fighting it. So there has to be this nuanced planning in the policy and at the basic dot center where a patient goes. They should not be made to feel that, they brought this upon themselves and it is to be blamed on them and it is a catastrophe. So this is where, right from addressing, like even healthcare workers, they should be sensitized, there should be training to mitigate the stigma, to raise awareness about how to not put all the burden on the patient. It is a team which is going to overcome TB, which is going to overcome stigma, where the way it happened with COVID, we are able to live with COVID in our society amidst it. We are not, initially, of course, it was, but how the way the world adapted, the same or similar uh, mechanisms have to be put in place to fight TB stigma.
Thank you, Debshri. We have a couple of questions for Dr. Rubandi as well, but I can see she's having some technical issues. So I'm going to hand over to my co-moderator, Deepti Chavan, in case there are any questions for my presentation, and then we'll circle back to Dr. Rubandi as soon as she joins. Thank you. Deepti, over
Thank
to
you,
you.
Ashna. Thank you. And thank you all for being a part of our panel. And it was in an interesting and enriching discussion. Ashna, I have some questions for you. What about stigma for gender and sexual minorities? Do you think there is any policy in place as such for that?
Thank you, Deepti. We do not have specific policies that look at addressing stigma for gender and sexual minorities. And this becomes an issue because the kind of stigma they face, and I was talking about this even yesterday on the gender panel, is dual in nature, which is that when you identify as a member of the LGBTQIA++ community, there tends to be a lot of stigma and discrimination just associated with that in society today. Alongside, when you have something like TB, which has its own baggage and stigma, that sort of becomes this dual burden that an affected individual needs to carry, and not and sort of addressing that and accounting for how that impacts their mental health. One, two, how that impacts their access to care, uh, because it's very difficult often, especially when in healthcare settings, these communities tend to face stigma and discrimination because of their identity. It's incredibly difficult for them to go approach people. In our work at SATB, we've worked with the community to identify what barriers they faced. And from some of their testimonials, we actually had stories where people preferred to risk death than approaching the health system. Now, that's a huge indictment of a health system if somebody would rather die than go and seek care. So it's really problematic that we don't have that. And when we do look at stigma mitigation, I feel like we need to do it in a layered way where we are addressing stigma for different genders, different sexual minorities, and taking a comprehensive approach to it. So,
Okay, so since Rubandi ma'am is here, can we ask her the questions?
sure. Hi, Dr. Ravani. Thank you so much for joining us. We had a question for you. In your presentation, you mentioned that caregivers tend to have internalized stigma to quite an extent. Could you just clarify, is this to do with the fact that they're associated with someone who has TB? And what measures can we really put in place to help mitigate that, because while stigma mitigation for affected individuals is undoubtedly important, caregivers are also their strongest support system, whether it's family or a health worker or whoever else. And what is it that we can do to address stigma at that level? Thank you.
Oh, thank you. I'm so sorry for the delay in joining. So I guess the caregivers that we were talking about in our study were family members, and I think that's what you were referring to rather than health
Right.
workers, correct? Yes. Okay. I mean, I think actually this is something we wanted to explore further, and we did further interviews actually because I think that a lot of this I think relates to just this sort of community high levels of stigma in communities related to TB and change in social status. You know, one of the, and it also there are probably also some differences related to whether the age of the person who has TB, because some of the caregivers we spoke to were talking about their children who had TB, and others were their young children who had TB, and others were talking about their adult family members who had TB, and I think there's probably differences there. One in the study that we did in South Africa, I think a couple of these were just a handful of interviews, and so a couple of their caregivers were worried about how the children would be, how their children would interact with their friends and the families of their friends in terms of the risk of transmission. So I think a lot of it related to the fear with the anticipated stigma as well as enacted stigma related to having a TB diagnosis. One thing that I thought was interesting for the caregivers of younger children was that the teachers seem to be often a protective factor. So I think that's important because one of the children who joined the interview talked about the fact that they didn't want to discuss their TB diagnosis with their friends, but they were willing to talk about it with their teachers, which I thought was interesting and a good thing. The other thing I'll say that actually didn't come from our data, but I heard more recently last week that I thought was relevant is it came up that in terms of the differential impact of gender on stigma, I think the study came from, I think it was from Peru, where they found that female caregivers internalized stigma related to the fact that their family member had got TB because they felt responsible for their child's nutrition, and that getting TB was a reflection of their inability to provide adequate nutrition for the child. So I think there's a lot of different aspects. So I think a lot of it, in terms of the recommendation, a lot of it is, I think, in terms of so I think two components that we at TB Proof have thought a lot about is counselling, and I think counselling that could be delivered to both individuals as well as caregivers at the time of diagnosis and throughout care, and then I think different interventions to improve awareness and decrease misinformation, which would hopefully then decrease stigma in communities. And I think is harder to I think that's where the contextual data is also very helpful to know what would be more effective. So in South Africa, community health workers identified stigma as a barrier to the cascade and suggested participatory theatre, so plays, to engage with community members. I saw that some of the data from the group in India that I presented in the study suggested that engagement with celebrities and actors could also be helpful. So I think those are some strategies that can help.
Thank you so much. We have another question for you. In terms of the drivers of stigma, you identified, this is very pertinent to our clinical settings in public health messaging. So how do we really work on reorganizing that to sort of address the stigma in TB? Because of course, in a clinical setting or in public health messaging, there is an infection control imperative, which is understandable. But how do we balance that against providing care that is equitable and accessible, where our clinical setups or our public health messaging is not ending up sort of engaging in institutional stigmatization of TB affected individuals? If you could just speak to that. Thank you.
Yes, that is a really important question. I certainly think about it a lot as an infectious disease doctor beyond just TB alone. And I think we've all thought about it. I think obviously we as a TB community, but particularly with the lens of the COVID-19 pandemic that continues. And I think one thing that I think being more engaged with TB survivors and affected communities, I think, has shown me is that the disconnect between, you know, what you were saying in terms of the public health response and individual care has been a real challenge for TB, and I think part of the reason that we have struggled to address TB effectively, because there's been a focus on the population health aspect. I think in some ways, in many ways, at the expense of really thinking about what makes high quality individual care. And I think obviously the two go together. And actually, if we provide high quality individual patient care with excellent access to diagnosis support, treatment supports, then again throughout the whole of the care journey, that also has an impact on public health. So I think a lot of it is around messaging, and I think in some ways the COVID pandemic can help. I currently live in the US, where like many countries actually, there's a real polarization in terms of mitigation measures against infectious diseases, from the perspective that we are all individuals, but within a community, and so our behavior affects each other. And I think one of the things that's been very challenging with COVID-19 is that we haven't managed to convey that it is I think we haven't managed to convey in countries that have not handled the COVID-19 pandemic well, such as the US, for example. We have very unequal societies where people, I think, are only focused on their own individual rights. And so I think some of it is to do with messaging in the community that TB is a disease that can happen to anyone. It is a disease that happens when you breathe. It's a disease that is preventable and curable. And I think those pieces are really key. And I think especially as we now have, and I think you had a panel yesterday about TB treatment, we now are getting better regimens that are less toxic, that are shorter. That I think will really help, but they only help so much as if we are able to support patients through that. And some of that is not just support through the medical aspects of care, it's also the socioeconomic aspects. So I think really trying to make sure to understand what are the different barriers that patients face that would prevent them getting treatment, whether it's, you know, do they have to show up at the health facility every day, which is not possible because they have a job, or they have caregiving responsibilities. So I think really understanding the different barriers and providing necessary supports is crucial. And the other thing, I'm just blanking on the other thing I wanted to say. Oh, I think, and the other thing is, I think, really to destigmatize TB. I was actually reading some interviews again today. These are just sort of at the beginning phases of trying to understand in urban and rural areas, again in South Africa, the impact of COVID-19 on TB. The interview I was reading today was with a community health worker, and one thing that really struck me was about the issue of trust, that community health workers are trusted figures within communities, but COVID-19 has really impacted that because of needing to distance, needs for PPE, and fears around infection. And one thing that this community health worker mentioned was that that really needing to convey to people that TB is not just some chronic disease that can't be cured. It was really important to let people know that if you take your treatment and have good support from the healthcare system, you can be cured and also reduce the risk to other people, because the community health worker was saying that people are taking treatment, but they start to feel better, and their disability grants or other support that they initially have goes away, and it's hard for people to continue. So I think it's really trying to understand those different barriers and be able to engage with patients to help get them through, you know, what is, as you have heard from Debshri, is really a challenging time in people's lives, but in a supportive and non-stigmatized way.
Thank you so much, Dr. Rolandri. Deepti, do we have any other questions coming in? Because I think we have 5 minutes and then we will wrap.
I have one question for you. When
Right.
talking about the role of law and accompanying policies in mitigating stigma, what can we do to ensure that affected individuals are not discriminated against, especially by housing societies and landlords? Because we see a lot of people complaining about they don't get a place to stay, or what do you think we can do to address that?
Thank you. So yeah, resident welfare associations, or whether you're renting a house or trying to buy a house, all of these, and particularly this tends to be an issue for affected individuals from gender minority communities, let's say trans people, or religious minorities as well. And what we can do here is one, it has to also be an internal change, right? Because a top-down approach as in stigma doesn't really work. So resident welfare associations need to have their own guidelines, and we've done this with COVID, so it's not like we don't have the capacity for it. They need to have their own guidelines where, again, they can balance infection control with with not stigmatizing the affected individual. And it's also very important to note that you need to create that awareness and communicate that to RWAs and house owners, that not all forms of TB are infectious. We've been talking about infection here, but it's actually only pulmonary TB, and that too only for the first couple of months, maybe. And once the medication kicks in, the patient after a few days is no longer infectious. Even while they are in the quote unquote infectious stage, it's not like if you're next to them, something will happen. It's also an airborne infection. So if they, this, it one is that one is really contextualizing what is a public health issue and what is discrimination, and sort of gearing that in terms of awareness campaigns towards RWAs, their own policies. And the third is, so you can rope in municipalities to actually have this, where you incentivize RWAs to provide this kind of accommodation, and there is some penalty if they don't. We can actually use those to our advantage. Civic laws can be used, civic policies can be used to our advantage, where we create this kind of environment. And also indicating that, again, the public health cost of this, that if you create an environment where somebody who's living in your building cannot identify as a TB affected individual, they are less likely to seek care, treatment, and if it's left untreated, as I said, TB can spread in the community. So our stigma and discrimination actually harm us more than they protect us, even though we come from a space of fear of infection, or trying to protect ourselves. That doesn't really protect us or the TB affected individual. What does is educating ourselves about what awareness measures need to be in place, what infection control measures need to be in place, if at all, and then operating from this space of also empathy. I mean, housing or building a home, everybody has this right, to be able to live in a safe space, to be able to be part of a community, and you particularly need that even more when you're struggling with a deadly illness like TB. So it's equally important to sort of operate from a space of empathy. Thank you.
Thank you, Ashna. And lastly, I would like to ask both the panelists, do you think we are doing enough to address stigma in TB? And if not, what more do you think we can do? Karuna ma'am, you can go first.
Yeah. Thank you, Deepti. I would not say that we are doing enough, but I would say that we started. And we to move forward, we need to learn several lessons from the existing systems. Like, say, for example, I wanted to talk when Ashna was saying ki COVID scenario. One of the important thing that happened for the benefit of TB because of COVID is destigmatizing the mask. So if pre-COVID era, if you see, when we asked to ask the patients to use mask, TB patients to use mask in the hospitals, I mean people with TB, there used to be a lot of concern ki why only some people are being asked to wear mask, and this used to be the beginning of a stigma. So what health providers used to do is they were also concerned and they would not wear the mask even for their protection as well. But now, because of COVID, what happens is mask has become destigmatized. I remember a few years back, we had this destigmatized, unmasked stigma and unmasked TB. Like there was a campaign in the union conferences around this. But now we are in a very good place. Like, could we put these as an infection prevention measures for TB in the in the health centers? So now, because this is an accepted, it's become an accepted. Everyone knows why to wear a mask. So this is no more a stigma. So this is some lesson that we need to see, and we need to tweak around the message for TB. So this can work for us. Similarly, the RW example which Ashna has given is again a great example. TB, people with TB, especially from the lower income people who cannot afford good nutritious food, having nutritious food during the treatment is very important. But because they cannot talk to anybody about this, they cannot talk, keep I don't have food in my house. And can we have that kind of community around who can provide nutritious food to people with TB who are not in a position to have? In quarantine time, we saw in COVID people sending meals and boxes to people, families who were in COVID quarantine and who cannot cook that. So I think some of these lessons, as a community perspective, as an individual perspective, we can take them forward to destigmatize stigma. But then this again, as I said, like, it's a bottom up. It's like communities have to come from this. Like, we cannot say some program people have to lay down this some rules and guidance for this. No, it is the communities who have to come. That is where we start talk about the Jan Andolan. For the health workers perspective, the prior question which Ashna asked, right now we don't have the TB preventive therapy as a mandatory guideline for the health workers. So if you think about the health workers, why they are trying to keep them away, because they also have a component of fear. Take the examples of medical colleges in Wardha and all. How many doctors and how many nurses have got TB, and we have also lost quite a few of them, health workers, for TB, right? So we need to also put prevention measures for health workers and address those fears so that they don't have to uh, you know uh, adapt these discriminative ways. uh,
Absolutely.
and one last point I wanted to talk, I'm sorry, there's a sudden power cut here.
Uh,
What I want to
Dr.
mention
Dr.
here is,
Sangeeti, I'm so sorry. Could we just jump to Dr. Ruvandi, because I think we're over
okay,
time,
okay,
so we just
yeah,
want to
yeah,
get
sure,
her
thank
opinion in as well.
thank
Thank you so much. Uh, Dr. Ruvandi, what more do you think we can do for stigma mitigation in India? If you could just give a couple of pointers, since we're running short on time. Thank you so much. All right, I think we've lost the audio there. Dr. Ruvandi, can you hear us? We can't hear you. Could you unmute, please? No. All right. I think we're experiencing some tech difficulty at that end, and we are short on time. So thank you so much to all our panelists for their wonderful presentations and for being here for the live Q&A. Just to close, TB-related stigma is something that we need to address as urgently as we focus on TB elimination. And we need to do this through multiple. And we need to do this.
Audio cut out thing. Can you hear us? Hmm. Um, phones, I think.
Hello? Yes, sorry. So sorry about that glitch. So as I was saying, we need to address stigma on multiple levels. And this is, while bottom up is important and while bringing in communities is important, equally important is, I think we need to simultaneously work on sensitizing health providers, on addressing institutional stigma, whether it's in workplaces or in educational settings. And we need to make sure that we don't have a one size fits all stigma mitigation policy, that we cater to the varying needs of different genders, different sexual identities. We just have something from Dr. Ravandi here, so I'm just going to read it out. And on that note, we're going to close. Definitely not doing enough to focus on stigma. Doing so should be a central theme of care.
TB survivors. If that came through.
Dr. Ravandi, could you just mute yourself? I think there's a disturbance that's coming in.
Yeah.
Thank you so much. I'm so sorry. It seems technology is staging some kind of uprising, but I'm going to read out Dr. Ravandi's message. We're definitely not doing enough to focus on stigma. Doing so should be a central theme of care, and contextually important solutions are needed. Involving TB survivors is key. Thank you so much for joining us. My abject apologies for the technical glitches. I hope you could hear most of what our lovely panelists had to say. Thank you to our panelists for being here, and thank you to my co-moderator, Deepthi, for doing this with me. And a big thank you to Survivors Against TB for putting this summit together. Thank you so much. Please stay tuned. We have other exciting panels coming up as well. Thank you.
Thank you. Thank you.
I'm Keuri Bhanushali, an accountant turned copywriter. I dance to de-stress and I write to give voice to my thoughts. I was diagnosed with MDR TB 10 years ago. More than the disease, it's the stigma that is harder to fight. I remember I went into a shell, scared that people might keep away thinking it's contagious. I wondered, who will marry me? Will this affect my siblings' chances of getting married too? I slowly learned that it is very important to talk about the stigma of TB. Silence was not an option for me. Remember, stigma impacts you deeply. If you have TB, talk to someone you trust. Don't suffer in silence. Let us fight TB together.
Life as an architect is so much fun. I chose this profession for its creativity. But not long ago, I thought I would never be able to design again. About 7 years ago, I was diagnosed with XDR-TB and I thought it was a full stop. Fighting TB was hard. However, the way people treat TB patients makes the fight harder. People make you feel it is somehow your fault. Why? Stigma affects how you feel about yourself. You feel you are not good enough. But love and acceptance from friends and family can keep you going. You learn to fight back. Today I have defeated TB and I am working full-time as an architect. Every day is a new adventure. Remember, TB can happen to anyone. There is a life after TB. Let's talk about TB. Let's end this stigma now.
So dear audience, participants, and my co-chair Diptendu Bhattacharya, welcome to the session on research and TB. Another year of the pandemic and the facing of both old and new challenges. I'm Nagesh Mistry from the Foundation for Medical Research. The challenges require four pillars of resilience, vigorous application, innovation, and introspection. All of this bears on this year's theme of redesigning the TB control program and strategies. In the compilation of this session on TB research, we bring you four presentations that reflect the four pillars I just mentioned. Dr. Mala Rao of the National Health Service of England and Senior Clinical Fellow at the Department of Primary Care and Public Health, Imperial College, represents introspection. Her talk will deal with how health structures will need to be redefined and repurposed to embrace the vision of comprehensive healthcare and universal health coverage. She will guide us to a roadmap using examples of how this has been achieved, even partially, in other parts of the world and the challenges we should anticipate. Dr. Amrita Daftari is Assistant Professor, School of Global Health, York, Canada. Her talk represents resilience. She has been a leading voice, along with others, against stigma in TB and has been a source of inspiration for many who have suffered the ravages of this disease. Her presentation will deal with research that shows how stigma mitigation should be internalized by the control system and not treated as an external appendage of TB control. We now come to Dr. Kalpana Sriraman, a biologist and senior research officer at the Foundation for Medical Research, who has undertaken path-breaking work in recent years in transmission and diagnostic research in TB and COVID. Her presentation represents innovation for the pressing problem of pediatric diagnosis in TB using a non-invasive mask-based technique. She will also dwell on a roadmap of how you take this technology from the lab to the field application, and hers will be an interesting journey. Lastly, Dr. Rashmi Rodrigues, Associate Professor, Department of Community Health, St. John's Medical College, Bangalore, represents the pillar of vigorous application. Using examples, she will highlight the advantages that digital, into bracket, adherence technologies introduced in recent years have brought to care-seeking pathways of TB patients. To the extent to which the problem of compromised interaction between provider and patient as experienced in the COVID pandemic can be reduced through the application of these technologies will be described by her. I hope this deck of presentations will stimulate key questions on the importance of research as a useful and not just an esoteric and academic exercise that can contribute to a meaningful redesign of our TB control in India. I would like to thank the organizers for their persistence in hosting this summit despite extremely difficult circumstances, and to the speakers on my panel for their willingness and effort to convey the essence of their research and their research interests. Now over to the speakers.
Hello, everyone. Good morning, good afternoon. It's a pleasure to speak on tackling TB stigma at the India TB Summit, just in advance of World TB Day. It's a real honor to share the stage with my esteemed colleagues, and thank you to FMR and Pi Consulting for convening us. Stigma disrupts the care cascade, right from symptom onset through to treatment completion and cure. These impacts I shan't discuss in detail, but they've been very well established in the literature. Stigma diminishes patients' quality of life, their clinical and mental well-being, as well as their social status, and at times irrevocably beyond the stage of cure. So tackling stigma associated with TB is really essential to tackling the disease itself. From a research perspective, I'd like to highlight two things. One, that regardless of whether stigma appears as an overt act of prejudice or an invisible fear or an internal trauma, the effects on people's engagement in the care cascade is visible, it is tangible. Second, stigma is a subjective construct. So what you might think of stigmatizing might not be the same as what I or patient thinks to be stigmatizing. We all do not have to agree on the look and feel of stigma to accept that stigma is indeed happening. Now, I spend a large time of my working with communities, studying the causes of stigma, because I think if we can pinpoint the drivers, we can create the solutions. And at its most obvious level, stigma is driven by the clinical effects of TB and an awareness of the same. We're dealing with a contagious disease with terrible effects from hearing loss to mental breakdown and death. It is no surprise then that TB is feared and stigmatized. At the underlying level, stigma is a function of inequity. Globally, as well as within communities, it is harder for people who are poor, unsupported, or facing other social challenges that may have pre-existed because of TB or in spite of TB to fight the stigma of TB. At a third level, stigma is driven by the systems that we've already put into place to tackle TB. Mandatory screening, testing, public approaches to notification and contact tracing, enforced treatment, isolation. These are routine, if not infectious, completely necessary infectious control practices. But if they're implemented without considering the inequities in which TB arises, then they can cause tremendous social harm. Today, stigma reduction interventions have largely focused on the micro or individual level, building people's knowledge about TB, building positive attitudes about TB through positive images, counseling people with TB and families on how to fight stigma, connecting people with TB to one another to build some solidarity and community of support. These are essential, and they have been successful. The problem is they're few and far between. They're the exception rather than the norm, and they barely reduce actual acts of discrimination, even though they have an effect on anticipated or internal stigma. The problem is that they only address some of the drivers, as denoted by the green boxes here, such as tackling some TB perceptions, some social messaging, developing some solidarity within pockets of people affected by TB. But the systemic drivers of stigma are left totally unchecked. So what is a way forward? Here's what Saurabh Rani, who many of you might know as a TB survivor, has shared with me this past week in a WhatsApp interview.
So stigma is a very, very big problem in all the countries that have tuberculosis. Apart from just people not knowing what TB is or how it spreads, it's also the fact that there are no protection mechanisms. For example, if I am getting stigmatized, I have no idea where I can go, what I can do. If people start isolating me, if my family decides to not keep me in the house, if I go to work and my boss says that, you're not supposed to come in now because you have this disease, or they just, they don't even do it formally. They just start behaving in a manner that I feel like I can't be here anymore. I don't know why there are no protection mechanisms. I don't know why there are no laws. I don't know why a patient is not aware if they exist. Like, what can a patient do to go and report discrimination? What can a patient do if they face this discrimination and need help? Who do they go to? Why is there not enough information out there that makes normal people know more about this disease, understand why they need to be compassionate, and let tuberculosis patients have the support that they need? If there is no social support and I'm thrown away when I need support the most, I have no idea how to cope with it.
So I'll take up what Saurabh has said and add to it in terms of a way forward for stigma reduction. One, we have to target the unchecked drivers of stigma. We may not be able to remove them altogether. For example, we cannot abandon the public health system, but we can update the practices that guide it. For example, mandating confidentiality and privacy into contact investigations and testing processes. We can't end inequities, but we can put social, economic, and legal protections in place to help patients work through those challenges during the course of treatment. We cannot attend to every comorbid condition, but we can certainly help patients to navigate the health system and sort of manage their treatment side effects through careful monitoring, strategic referrals to help them to combat the stigma associated with those various conditions. We can reduce the fear around contagion by giving equal attention to recovery, for example. Number two, consider where we can get the greatest bang for our buck with regards to stigma reduction. Some colleagues in South Africa have studied stigma to be greatest in people who are entering the care cascade. This suggests that reduction efforts will be most impactful at the stage of symptom onset, presentation, screening, and testing. In fact, we know that huge losses in the TB care cascade are happening exactly here, right before patients even begin treatment. Three, later in the care cascade, we know that mental health is a huge driver of stigma. The research suggests that attending to mental health issues will alleviate patients' stigmas, and alleviating stigma will improve their mental well-being. So let's put investments into this. And finally, let's branch out to our friends who are working in other infectious disease spaces. Beg, borrow, steal their ideas. Think, for example, about the innovative private contact tracing methods that have come about during the COVID era. Raise awareness about and celebrate the end of isolation periods and not just the beginning. Engage people affected by the illness in policy and program level decision-making because they are allies. Offer choice wherever possible. Every little thing within TB does not have to be standardized. And attend to vulnerabilities with meaningful investment at the intersectoral level. It is possible. The TB response can and must attend to mental health issues. We can and must deliver monetary as well as legal security. Families in isolation and quarantine do not have to be excommunicated emotionally and mentally. These types of strategies could afford us opportunity to address all of the drivers of stigma. For every other aspect of TB, we think, what's the cause? We develop the solution. Well, let's apply that logic to stigma. It's caused by clinical and systemic factors, structural inequalities. So let's produce a commensurate, multi-pronged response. Individual level interventions are crucial, but they're not going to be sufficient to tackle those big underlying drivers of stigma. I'll leave you with a few resources, some of which I mentioned in previous slides. And I also thank you very sincerely for your time. I'd be happy to take questions. You can email me anytime. And a huge thanks to Saurabh for sharing his opinions and his voice. And of course, to the fantastic communities who are already working on TB destigmatization. Thank you.
Hello, I'm Dr. Rodriguez, Associate Professor at the Department of Community Health, St. John's Medical College, Bangalore, India. I will now speak about my experiences with digital technology and research for TB in the Indian context. Digital technology has taken over the world. With 1.2 billion mobile subscribers, half of who are smartphone users, we in India are at the forefront of the digital revolution. Mobile phones for antiretroviral therapy was one of the first digital health interventions proven successful. This was in Kenya in 2010. It was then that the healthcare sector, especially public health experts, realized the potential of digital technology. The research group that I was associated with at the time also realized its potential and decided to explore the effect of the technology in the Indian context, though with not as successful an outcome. This was in the year 2014 when we first saw the results of the Hevent mobile phone trial. From there, digital technology for healthcare has made tremendous progress. In the current scenario, it has been used for telehealth and self-care, virtual reality, remote monitoring, artificial intelligence, big data, and digital therapeutics, to name a few. However, identifying the need and developing the technology to suit the user or the beneficiary is a long process. Preparation and exploration are the first step in this process, followed by development, implementation if successful, and sustainability of the intervention. In my work, where I study the effect of adherence support interventions for TB, we have adopted a similar approach. While we did have interventions in mind, we also explored what patients with TB thought about the use of mobile phones for adherence support and adapted the intervention to suit their needs. The technology was found hypothetically acceptable to patients However, would it actually be acceptable and would patients use it was the question. We did run into some issues with acceptance when we did a pilot of video DOT. However, patients were more accepting of the technology when we began the randomized controlled trial. As of now, we have just completed the randomized controlled trial with 430 patients, half of whom received the intervention and the other half who did not. The results are awaited. I had also worked with Microsoft Research India to develop the 99 dots intervention in 2013. While it is not as objective as the video DOT, one of the reasons why I prefer video DOT, it is an intervention with potential. Then we have sensor observed treatment or SOT. We will first try to explore this before we proceed to see if this is effective. The Digipill is a pill with a sensor which gets activated by gastric acid when swallowed. It then sends a signal to a wearable device like a digital watch or a sensor or to an app on the mobile phone. Will this be acceptable? And is there a need for such kind of monitoring? Is of course the question that has to be first answered. Digital technology has been widely used for TB in India. The Nikshay TB notification portal is the hallmark of this. We also have nutrition support via mobile applications, artificial intelligence for diagnosing pulmonary TB radiologically, and the new Integrated Health Information Portal, which promises to integrate all patient healthcare records. Its feasibility, given the current scenario, however, is yet to be realized. Finally, and most importantly, a patient-centered approach to healthcare interventions, especially digital health interventions, is the key to success. It is absolutely essential that patients and healthcare professionals interact extensively and the healthcare professional takes the patient into confidence and discusses available options such that patients can make an informed choice. I am a strong believer of this. Thank you so much for your time.
I'd like to begin my talk by thanking Dr. Nargis Mistry and the organizers of this summit for inviting me to share my reflections and perspectives in this session entitled TB and Research. The specific focus of my talk is strengthening comprehensive primary care, an essential means to ending TB, and in particular, what sorts of research will enable comprehensive, affordable primary care to be achieved. The Global Tuberculosis Report of 2021, published by WHO, offers a stark reminder of the situation today. The director of the WHO Global TB Program has highlighted that the world stands at a crossroads. Just to recap on the facts, the 2018 first UN high-level meeting on TB committed governments to a number of treatment and prevention targets to be achieved by 2022. But the reality is that the COVID-19 pandemic has reversed these gains, set back the fight against TB by several years, and widened gaps in access to care. There has been a large global decrease in people newly diagnosed with TB and reported, with India, Indonesia, and Philippines worst affected. There has been a reduced access to TB diagnosis and treatment, resulting in an increase in deaths. Previous declines in incidence have slowed and almost halted. TB prevention treatment and treatment for MDR-TB has declined, and there is a substantial fall in global spending on TB. Now, and this is the reality against a background where there is already considerable knowledge about TB and how it may be managed. TB is an ancient disease. Its links with poverty unsafe housing, undernutrition, smoking, diabetes, and HIV have been well known for decades. The fact that a diagnosis of TB leads to discrimination and stigma are additional and recognized challenges. But what is encouraging is that despite the enormity of the tasks ahead, the world signed up to the SDG target to end the TB epidemic by 2030. And this was followed up by the more specific targets for 2030 set in the End TB strategy to achieve a 90% reduction in TB deaths and an 80% reduction in TB incidents compared with 2015 levels. And there are targets for further reductions of 95% in deaths and 90% for incidents by 2035. And it's also recognized that integrated patient-centered care and prevention are absolutely key to achieving these targets, with appropriate research rapidly providing the evidence base required as we strive towards these goals. Yet the history of health system strategies is littered with failed vertical programs, and in parallel, a mountain of evidence has been published, which demonstrates why horizontal comprehensive primary care within a framework of universal access to health is key to achieving public health goals, such as the End TB strategy. And it's clear as to the reasons why this is the most cost and clinically effective way forward if we reflect for a moment on the late Barbara Starfield's definition of primary care, a trustworthy first point of contact for most health problems, such as a cough, a holistic and whole person focused service which can detect the person with TB among those who present with a cough, provides ongoing care over time through diagnosis and treatment, thus improving compliance, coordinating care for individuals, for example, addressing their TB, HIV, and nutritional needs at the same time, gatekeeping, referring to hospital when necessary, and very importantly, addressing the wider determinants of health, the risk factors for TB, such as smoking, poor housing, and poverty. So what research may ensure that these targets, challenging as they are, may be achieved? The key priorities have been clearly highlighted by WHO. The discovery, development, and uptake of new tools, technologies, treatments must remain a priority. And the research community has for many decades shown extraordinary vision in tackling these dimensions of research, the rapidity of development of the COVID vaccine being a very important example. The second priority is for research to benefit implementation, impact, and innovation. And one group of authors writing about the challenges of TB control in India captured the issue very well when they concluded with, if we eradicate poverty and undernutrition, educate the masses, and eliminate the stigma attached with TB, we can hope for a disease-free future, confirming that vaccines and drugs alone will not help achieve the equity of access to care, which is also essential. In this regard, there is much we can build on our learning from the pandemic and the speed with which the world and frontline healthcare workers innovated to meet extraordinary needs. It taught us that the appropriate starting point is to ask, what questions would primary care staff like answered from the experience of delivering care? And are there questions related to digital solutions, vaccine hesitancy, poverty as a barrier to patients accessing care, which they feel should be answered? And it is these answers which will help address the barriers that have beset delivery over the decades. Both qualitative and quantitative research are hugely necessary. Indeed, I might go as far as to suggest that it is case studies which are often powerful in persuading system leaders to shift policy. Affordability is key for individuals, households, and governments. So we need to build in economic evaluations into our research. And it's also the case that quality improvement research is surprisingly uncommon in the developing world, and yet it is highly effective as a means to understand what works. Methodologies for developing and evaluating complex interventions may be more suitable options for assessing the benefits of some community interventions, for example. We also neglect to evaluate workforce development innovations, although we recognize that old-fashioned classroom-based teaching may not work. And it is also underdeveloped in terms of research into multi-sectoral solutions where people get together to address medical and wider interventions. But above all, we need to let primary care staff lead the research strategy, and we need to develop and strengthen primary care research per se and invest as much in that as we do on finding medical solutions. So in conclusion, the burden of TB remains high, but drawing on the words of the Director General of the WHO, I believe that with the right research and delivery and the determination, solidarity, and equitable use of tools, we could end TB. Thank you for listening.
I thank the organizer for giving me this opportunity to talk. Today I'm going to talk about the non-invasive diagnostic approaches to childhood tuberculosis, with a specific focus on the smart PCR method, which we are working on. It's a combination of sampling using a mask with RT-PCR. I don't have to tell this audience the situation we are in, but I would like to re-emphasize such situation in children. TB in children is a major cause of mortality and morbidity. Yearly, we have about 1.2 million children falling sick with TB globally, and over a quarter are there in India. What's more alarming is that more than 1 in 2 children are are getting missed out, or not getting diagnosed, or left untreated. And the mortality can be as high as 90% among the children who are untreated. The major problem, it is a major problem, and we'll have to address this now. 70% of them have pulmonary TB, but the issue with diagnosis is that most children cannot produce sputum. Producing sputum is a challenge because they do not have symptoms or the bacterial load like adults. And often physicians have to use invasive methods like gastric lavage, nasopharyngeal aspirate, and in extreme cases, even bronchoalveolar lavage to collect samples for microbiological diagnosis. And this is important for starting the right kind of treatment. But with invasive methods, the problem is that it is very traumatic to the children and even the family of the children. And currently, the samples have lower sensitivity with the standard tests that are available. Moreover, it requires skilled infrastructure that is inaccessible for most children in India. This is reflected in the India TB report. If you look at it, among the notified pediatric TB patients, 25% in the public setting and 8% in the private setting only had microbiological diagnosis. The rest were clinically diagnosed and treated. So this can lead to under or over diagnosis sometimes. So the emphasis globally has been on developing non-invasive, non-sputum-based methods for diagnosis of TB in children. There is a strong emphasis in using stool and urine because these are all easy to collect samples in a routine setting, and it can be collected in any setting possible. Stool is combined with GeneXpert for the detection of TB, and several kits have been developed for processing stool. WHO had reviewed it last year, and data from 9 countries shows that overall, the stool method has a sensitivity of 53%, but it has a good specificity, and that's why WHO is recommending for its use in routine setting in conjunction with other methods. Urine is combined with lateral flow tests. The current one in development, which is most promising, is a Sylvam TB lamp from Fujifilm. The WHO is going to evaluate this year, but a recent meta-analysis shows that it has about 51% sensitivity and 87% specificity. We need more approaches for diagnosis of TB in children. At FMR, we are working on a completely different approach to address this issue. We all know TB spreads through aerosols, which is expelled by patients either through coughing, breathing, or even talking. And these can be captured to understand what's happening inside the bacteria. At 5 years, for the last 5 years at FMR, we are working on this to develop a method to capture these bacteria and understand the inner workings of it. So what we realized during this is that we could use this method to detect 96% of the TB patients whom we had. And what's more interesting is that we could detect TB even in patients who could not produce sputum, and even after initiation of treatment. This method, being a non-invasive method, we aim to evaluate its potential for detection of TB in children. So we call this method now sampling with mask. What we do is we ask the children to wear the mask for 10 minutes, ask them to breathe, cough, even recite a prayer, and whatever they would like to do. And we did this for 10 minutes and collected the samples. So we normally we use a membrane that is attached to the inside of the mask. So then we ask the patients to wear the mask, and the membrane is then collected and used for either gene expert or sorry, I just this slide I would like to redo it again, please. So we did a pilot project in children to test this method for diagnosis of TB. We call this method now Smart PCR, sampling with mask and reverse transcriptase PCR. So what we do in this method is we ask the children to wear a special mask, which is lined with a membrane for 10 minutes, and during which we ask the child to talk or recite. If they want to do even recite a prayer, we encourage them to do and intermittently cough and take, breathe in between. And what we did was we collected this membrane and tested for TB either by gene expert or RT-PCR. And we did this in 3 sites in Mumbai, one at BJ Wadia Hospital for Children with Dr. Ira Shah, a private TB clinic of Dr. Vikas Oswal, and JJ Hospital with Dr. Shashank Mane. So what we found was that this method could detect TB, and it was comparable to gene expert positivity in the same patients in the sputum and GN samples. What's more interesting was that when we did the gene expert, we could not detect so many patients, but with RT-PCR, we detected more patients. And what we think is that because RNA is there in the bacteria much more than the amount of DNA which is used for detecting in gene expert, we think the method was more sensitive than the gene expert in our samples. And what's most interesting was that we had few TB patients who were gene expert negative, but was positive by Smart PCR. We could pick up these patients, and we could even pick up a subclinical TB in one of the control patients who were later confirmed to have TB. So the method has promise, and the sampling is easier to do. It requires minimal training, and it can be performed at any under-resourced settings. However, the RT-PCR requires a special lab, and with COVID-19 enabling RT-PCR labs even at district level, this could be harnessed for testing. We are in early development stage. We've just recently received funding from USAID through PEER program to simplify this diagnostic workflow to test conditions for remote sample collection and to develop the DRSA. And we also will be exploring with experts to develop an age-friendly mask and membrane kit. Thank you for listening in, and I would like to thank my team at FMR, the study partners, and their associates who are part of this project. The study was funded by a private donation from Mr. Godrej, who is trustee at FMR and an industrialist, and also through institutional grants. I would like to specially acknowledge India Health Fund, who funded the adult study from which this study emerged. Dr. Varinder Singh for suggesting us to try it out in children, and Dr. Raghuram Rao at CTD for facilitating JJ as the center for the study.
Good afternoon, everyone. I am Diptendu Bhattacharya. I am the co-chair of the panel of the TB Summit 2022. Our theme of the summit is Redesigning TB Care for Equity and Access, and the title of our panel is Voices from the Field, TB and Research. On behalf of my co-chair, Dr. Nargis Mistry, and the organizing committee Survivors Against TB, I would like to congratulate and thank our eminent panelists for their wonderful presentation. The insights are extremely valuable for us, those who are persistent to believe that we can defeat TB. Each year, TB is claiming an estimated 1.9 million lives, which are comparable to the global pandemic COVID-19. Yet, we are significantly lacking in the areas of vaccine development and drug discovery. For example, the ratio of vaccine candidates in those two diseases are 1:6. And if we count the vaccine available, the ratio is much bleak. This contrast is much stark when we apply the same for India. But we have to remember that the research in these areas are our only hope. I would like to thank Dr. Kalpana Sriraman for highlighting the importance of new diagnostic approaches on the pandemic TB, which is at constant risk of developing the severe form of the disease with a high mortality rate. I am sure that her detailed discussion on the challenges and the approaches to this matter is going to produce extremely valuable responses. I would like to thank Dr. Mala Rao for posting and pointing out the limitations of vertical programs of care and how evidence-based strategic changes around comprehensive primary care ensures universal affordable access to multi-sectoral, multi-professional care effectively. Her presentation indeed justified the assertion, and I would like to recommend further research on high-quality primary care approaches. Dr. Daftari has presented the case studies from others and her own work on how the manifestation of stigma around TB has impacted the shape of the situation. She also highlighted what are the contemporary responses to reduce the stigma. Her exposition of successful application of innovative critical framework around stigma shows us that all hopes are not lost yet. We thank you, Dr. Daftari. Last but not the least, Dr. Reshmi Rodriguez has made an excellent point on the integration of digital technology to improve adherence to the treatment. Though admittedly, it is present in the current system research suggested that it is not exploring full potential. Thank you, Dr. Rodriguez, for exploring different areas of digital technologies, helping us in the diagnosis of tuberculosis via AI, DOTS therapy, and monitoring nutritional support for us. I wish to thank her and all of you once again on behalf of my co-chair and the organizing committee SATV for giving your valuable time and heartiest effort towards the success of the event. I would like to now open the session for question and answers. Thank you.
Hi, can we take any questions from the audience? So one, should I? You
can read out the question.
There is one question that we have, which says, why do we see such a great divide in TB research? We see very little commitment to TB research. Is it because it is primarily affects poor people in the low-income countries? The role of nutrition in TB and how programs can converge with this? How can current nutrition programs work better through convergence? Digital adherence has been seen to be useful, but does not replace the human connect. Do we see that patients feel isolated because of this? Also, the availability of these tools at the grassroots is a question. Now, would any of the panelists or the speakers would like to answer this? Mala, would you be able to answer it to some extent?
Yeah, well, firstly, thank you so much, Nargis and Diptendu, for an excellent session. I learned so much from just listening to my fellow speakers. So thank you for an excellent session. I think you asked several questions, Nargis, and my first answer is yes. It is a disease predominantly prevalent in the developing world. And I have no doubt that that underpins the underinvestment in TB research, why it remains quite neglected, and why it is we still don't have the kinds of solutions we need for equity of access to care, and the the elimination of things like stigma, which continue to be barriers, in addition to vaccines and therapies and so on, particularly for MDR-TB. So I think there is a bit of that lack of interest in things that are predominantly concerned with developing countries. I think it's also the case that primary care research is neglected, and it isn't that I would bang on about this because this is my pet topic. But if you consider the amazing digital technologies that are being trialed and the sorts of mask-based non-invasive diagnostic techniques that you're researching, what better place to test these than if we had a comprehensive primary care setting where a complex intervention which brings in the use of digital technologies, the use of these modern diagnostic techniques, the use of modern ways to communicate with patients, the commonness of this disease and why we should do away with stigma, bringing the family in, educating the community, and making sure that we routinize treatment, we provide the best forms of treatment, but we also make sure that this is done in a way that it's accessible to a woman who's pregnant and has TB, or an elderly man who has TB, or anybody who has TB, but also other sorts of things for which they may be receiving care. So I think underinvestment in that kind of complex interventional research is another big reason why we're not able to bring all of this together and form one solution for this. So thank you for a good question.
So this is from Vashishta, and maybe Rashmi would also like to add on to what Dr. Mala said. Rashmi?
Yeah. Well, I think, yes, digital technologies, I think from a research perspective, because I've worked a lot with digital technologies, play a very important role in enabling, treatment adherence, health seeking, etc. But I think we a lot of times forget that patients are the ones that we need to reach out to. And there are several factors that kind of promote health in an individual. And if we do not take those factors into consideration, any amount of digital technologies that we have will not really succeed in the end. Because I strongly believe that the patients who are primarily involved in using these technologies and for whom we build these technologies should actually be the focal point of whatever we develop. And we need to take in patients' perspectives into the research that we have. Because without that, I sincerely do not think that any research that we do will go a long way. And I hope I have kind of answered the question, perhaps.
Yes.
I have a question for Dr.
Yes, go ahead.
Okay. I have a question for Dr. Rodriguez. Since I am myself a survivor of tuberculosis, I have got MDR-TB for 2 years, and I have to drop my studies in IIT. So I have a specific questions towards you. I have always advocated that the treatment of tuberculosis is not only the medicine, but also the mental health support along with that, which was completely absent during my time. And I had no clue how to go with that along with the medicine, how I have to cope up with the mental challenges. I have no awareness of that. So you have done with video conferencing and direct observed therapy through video conferencing. My question is that how that trial has impacted the patient, and is that any hint that it will be helping us to deliver the mental health support along with that through video conferencing and all that tools?
Yeah. So what I really think is that we cannot use digital technologies as a standalone. in these settings, we absolutely need to have a very strong counseling and mental health component. And from what I understand, there's not much of mental health work that has been done with tuberculosis. And we are currently doing some work on it at the moment, though we do not have too many results with that. And my sense would be that you have the technology, but you also have a very strong support surrounding that technology for the patient. So it's not just that the patient interacts with the system, but the patient also interacts with the healthcare provider, the counselor, and the other people involved in patient care. So it should be a team approach, with digital technology being one component of it, but not the sole component of it. And yes, I think mental health, yes, even digital technologies have been used for mental health, and we could, through this existing system,
like group
also
counseling.
provide health. Yes, exactly. Yes.
If I may just add to that, Tendu, there is the thing of the concept of the lay counselor. So it is possible that if you are dealing with the community at large, you could develop within the community lay counselors, and these could be trained by digital technologies like ECHO and so on. So you could use digitization for training, and these models are available. I know NIMHANS has been quite involved with this sort of training. But at the community level, where human contact is definitely important, as Rashmi says, to get that supportive ecosystem, you need to train what we call lay counselors, not professionalized counselors, as we know they are short in supply, but a whole horde of lay counselors could be deployed at the community level to give that supportive ecosystem.
Yes, ma'am. That's why I just wanted to put out the word, the group counseling, like people who have similar kind of problem can have a session, because now everybody is that much of digitally literate by these 2 years of pandemic, that we have the reach which we hadn't. When I had this one some 7 years back, we hadn't that digital reach at all. So I hope this might be a good solution coming forward. If we have done more research in this field, so we can have a comprehensive approach on that.
That's right.
Thank you, ma'am.
Yeah. So I don't see any other questions, Diptendu. So if you would allow me, could I just put in a comment, if I may? Yes, Mala has something to say. She's got her hands up. Yes. Mala, please go ahead.
Nargis and Diptendu, it's just supporting what you've just said. And going back to the first point that Rashmi made, which is the need to engage with the patients to understand whether digital methodologies are actually acceptable and will improve compliance. I mean, I would even go to the point of questioning access, because the COVID, one of the things that it exposed, even here in Britain, is the extent to which there is digital poverty in our populations, and how there was this message that the whole nation could homeschool its children, and in Britain there began a discovery that actually there are substantial proportions of homes that do not have access to laptops and the ease of access that we believe there is. And even though we put out figures such as 1.2 billion users of mobile technology and this and that and the other stuff, I think there is a bit of gender inequality in use of digital services. I noted that a good 10 years ago. So there is an awful lot of teasing out that needs to be done. And so, you end up recognizing that it's got to be a hybrid approach for ensuring the most effective compliance and access. And what better than in a multidisciplinary primary care setting where patients and families are well known. So if the same person is consistently offering that digital advice on a line, then because you know the person and you know that if you wanted to, you could go and have a face-to-face contact, but you don't need to because you're rushed for time, and you can do that with a friendly person who you know, rather than an anonymous person who changes every every time you speak to them, it's a new person from an anonymous program based somewhere in a teaching hospital in Mumbai or whatever, but it's your local primary care service, which is offering the lay counselor, the doctor when required, and so on and so forth. What better setting in which to do that and ensure that the whole family is looked after, irrespective of their needs, including TB, rather than making TB something very separate to all the other family needs. So I think there is much that we can do to tease these things out if we have the right kind of research. So thank you.
And I think this can be extrapolated into the workspace also, that who are the patient where he is working and their colleagues and their boss, so what they are expecting from the patient and what patient should expect from them. There should be a constant before the treatment starts, there should be a information or a sit-in where we can discuss the possibilities, what can happen and how the people can support them. So this is an approach also we can make to ensure that comprehensive primary care is given to the patient, so that there are the pressure is distributed throughout the system, not only one person or two person itself.
Yeah.
Totally
To answer further Vashishta's question about the lack of research in tuberculosis, if I may just interject with an observation that biomedical research at the moment has picked up quite a bit of steam as far as TB is concerned. As Mala quite rightly said, there is a dearth of research into the complex interactions, particularly for the field. Field-based research is not that well taken up. It's assumed, certain things are assumed, or certain sort of caveats are assumed, but it doesn't happen in a systematic and in a robust manner. That is unfortunately the situation here in India. We know, for instance, that nutrition is very closely linked with TB historically. It's not rocket science or anything, but the actual research into malnutrition, what sort of supplementation is to be given, and so on, while it's done by certain researchers at the field level, the timing of such interventions, how do patients in a sort of through a biomedical paradigm respond to that supplementation? Is it given at the right time? How long it needs to be continued? That is not investigated thoroughly enough at the moment. And that brings me to my next observation is the fast tracking of research. Since this whole session is on research and redesigning research paradigms, I would like to recommend that there should be a little bit of fast tracking of research to evidence to the practice pathway. And I'd just like to ask my colleague here, Kalpana, who's been working on this diagnostic mask-based method for pediatric TB. How long do you think this journey is going to take? And if you had to speed things up, what would be your views on that it gets into practice as soon as possible? It's just devil's advocate.
I think with last 2 years, we have seen that things can really magically turn into a really fast process. So when I started off with this, I was a little skeptical. I was looking at a 4 to 5 years term, but with what's happened in last 2 years, I think it is possible to accelerate research given there is a will to do it. And now that steam is there with COVID, I think if we can pile on to what is happening with COVID, we should be able to translate our research much sooner in the field, and that's what is needed, because the time we've lost, whatever gain we had in TB in last few years, is before it gets deteriorated further, we should catch up on that. And I hope that at this moment, I think I'm hopeful, and it looks positive to me that maybe in 2 years' time, given all the things fall in place, we should be able to realize this as a technology which is usable in primary level settings. That's my thing, and it's really hopeful now.
I think there is.
Sorry,
Yes,
go ahead.
I think there is a question coming, and that is also my point all the time where I speak. When there is a systemic gap between the research and the policy. So this is the big question coming from Chapal sir also, that how to bridge this gap and how to people or patients should understand that what they should demand from the system which they are receiving care from. So can you please comment on that? How to bridge this gap?
Any one of the panelists would like to respond to that? How do you bridge the research and policy gap?
Yes, ma'am. Mala ma'am.
Yeah, let me begin, because this is something I've been debating and trying to get around for much of my career. You're absolutely right. There's a mountain of evidence that's buried deep in the pages of very distinguished journals, and even with interestingly important things like the role of aspirin in heart attacks, whatever. The lead time has been about 20 years or more to get it into practice, and we can't afford that with TB, and we can't do that for every disease condition. What interests me is even taking a lesson out of the setup of this conference. It's not just a group of researchers who have pulled this together, but you've got journalists, you've got industrialists, you've got all sorts of people who have taken an interest. And I see that beyond doing the research, getting investigative journalists involved, and there are so many, and I'm also very excited, not that I don't value male colleagues and the research they bring, to be in this panel that's full of women presenters. There is so much power that women are bringing to journalism and research, and plugging that gap and taking the evidence out to communities. And we're talking about to the grassroots. That is just so important. And in the primary care research modeling project that I was leading in Kerala, right from the start, the panchayats were brought in and were asked to own the project. So if we were trying to solve a TB issue, we said it isn't just the primary care team based in the primary health center, but it's everybody's own responsibility, and bringing that whole community together, bringing local journalists and news reporters together to share the ways by which this can be resolved, and especially pointing to the how common it is, and how generally easy. Well, I don't want to devalue the treatment, but actually treatments exist for TB. So to demystify TB and to destigmatize it, I think these sorts of unconventional resources. In general, we think, oh, we'll do a bit of research. We will have to share the evidence with government, and government will bring in a policy. I think we need to start thinking of how we use social media, journalism, helpful lobbyists to come and campaign on our behalf and ensure that there is policy change as quickly as possible.
And that is, I think, the true meaning of community engagement, that we don't view the community merely as a target for our research. We actually make them co-own the research. We discuss even sometimes research methodologies and not just the findings with them. And sometimes they can give us very valuable leads also. I think researchers around here probably have to gravitate to that type of field-based research. And that's something that will come about with constant prodding from mentors who understand the importance of this form of community engagement. It's important to know your technologies on the molecular level things, but unless people perceive its value, their use also will be limited in getting the efficacious results that the researchers and the scientists desire. Unless there is a connect through journalism, through providing health information, through constantly reinforcing, it's just not once is not enough, through consistently reinforcing these messages, we can bring about change. There is no other alternative in a system such as ours. We have to keep on pushing, pushing, and pushing to the best effort that we can. And as soon as scientists realize it, that track that I talked about, from research to evidence to practice, that too will speed up.
If I may add here that I think as scientists, we need to understand that we need to go out in the community, and there should be an opportunity to create that interaction between scientists and the community. To so only then we can realize what needs to be done and how we can translate our research to the policy level. So that I think there is a need for also make the scientists and community interact.
Yes, Chappell's made a statement also. How do you think we can demystify TB research? So, yeah, scientists are atrociously bad at explaining, with the exception of those present here. Sorry, but scientists basically are atrociously bad in presenting research. They get into such technical jargon that nobody else can understand. So basically, there is an interface required. And there are lots of people around. I see on emails coming to me all the time. Can we translate your research for you in simple terms? And again, we must be careful in this country not to just limit that to the English-speaking people. We need to get out and make that information available into the local dialects, into the regional languages, and so on. So it needs to be demystified to a wider audience, not just the English-speaking, maybe the Times of India, and pardon me, also the Indian Express, but we need to take it down to the regional journalists. And that's extremely powerful media where you can help to demystify. And also, of course, being a major disease of this country, there also needs to get into some form of health education, even at the school-going level, so that children are brought up with some basic knowledge of the diseases that confront this country and what they can do about it. And who knows, somebody innovative might bring about a paradigm change in TB research and TB control. So it's
also
reaching out. Yeah, please go ahead.
Also, if we include this thing, that means I also try to advocate like that, so that if we reach out the children's especially, we can target couple of things at once. That one, destigmatize the disease itself, and number two, how to approach the disease itself. So it is very important to do it from the very young age, so that the policy level is automatically streamlined through their behavior and actions and learning from as a syllabus, as a child, at a curriculum which is they believe and they adhere to the most. So whatever we have learned, that is our school level studies, which has made the foundation. So it is very important to include these things in our academics, from not only from the college level, but I think it is very much needed in our primary education system too, so that we can destigmatize this disease, especially in the country like India.
Sure. Yeah, Mala, go ahead.
I guess I absolutely agree, and Diptendu, the other benefit is to link it to, for example, anti-smoking.
Yes, other addictions. Yes.
So to link it to risk factors, and know that a few children out of every 100 who've been sensitized to the education will behave differently as a consequence of what they've learned at school. So that's really important. And I guess as we're running out of time, one of the other points that I thought might be mentioned, and I thought I should, and especially to draw attention to what a pioneer you have been in drawing the links, for example, with building.
Yes, of course.
I think we lost the link.
We've lost the link. Yeah.
Indoor air pollution. So we also need to think of novel research, which is maybe just observational studies of where housing packs people in poorly ventilated homes, and the levels and incidence of TB there compared with others. That policy change is complex, because whole governments have to be and property developers
sensitized, absolutely,
and have to be sensitized. But it's innovative, novel, and we can bring in building design and building certification people into that. And I urge you to carry on down that route, because it's such an important area of research,
absolutely,
which
absolutely.
you've been a leader in, Nargis. Thank you.
for Dr. Rashmi and Dr. Rao, with regard to technology, how do we focus on health worker skilling? Because the grassroots workers are often left out with health technologies and overburdened. Yeah. So I completely agree. Yes, please go ahead, Dr. Rashmi. Go ahead.
Yeah, yes, I know. I completely agree. And I think this has happened ever since we have health workers, community health workers, ASHA workers, ANMs, Anganwadi workers, who actually are out in the community, are at the grassroots level, who provide healthcare, and they have always been overburdened with technology or without it. And yes, the question of their skilling comes in, but I think what's important is that we try to identify those technologies that will make the most difference, so that we give them just the limited technologies that are really useful in the community. Moreover, integration of these technologies into maybe a common system would also perhaps be more useful, and it could save people from a lot of time, and energy, and resources, I would say. And I think therefore what's important for us is, in a way, since you're talking about skilling for, I would presume you're talking about skilling for the technology. Yes, we will have to perhaps even over time build in skilling into the technology itself in the long run, and see how that works. Because what I've seen is, in the community, to a large extent, healthcare workers are now exposed to technology. Yes, and yeah, and they are taking it on. So it's, rather than saying we should restrict ourselves from overburdening them, we should, I think, try to enable technology to support them, and through that to ensure that they're skilled enough not only to use the technology but also to provide healthcare through that technology, is what I would think.
Thank you, Dr. Rashmi. Mala, do you have a quick comment before we...
Quick comment. And I absolutely agree with Rashmi, but it's also, it's about using technology and how, training healthcare workers to do it, including lay workers, which is being done. But it's the use of technology to do multiple things. And that's, if you have one teleconsultation with a family, then you need to be able to, and you need to be trained to to ask about and follow up on the TB, on the pregnancy, on the older person's diabetes in the family, a problem that a child has had, and make sure that you bring about economies of scale, both for the caregiver as well as for the family, and that's when it works. And I think our training of healthcare workers is spectacularly lacking in understanding how they do that in an opportunistic way, while at the same time they're thinking, well, I sense a level of depression or whatever, so I need to have a face-to-face with this person. So even at the teleconsultation, you're making some judgments. That kind of training is absolutely essential. And the other thing is, digital programmers and developers need to take account of the needs of the healthcare people. It's not the other way around. Even in the NHS, we find doctors and nurses frustrated because the computers do not do what they require it to do. And so the way it's developed needs to take full account of the needs of healthcare, so that the digital technologies make that easier rather than add to the burdens of healthcare workers. So thanks, Nargis.
Thank you very much. Diptendu, I think we're out of time. Yeah.
Yes,
So you might
3:15
like
it
to
is.
So would you like to just make some closing? Yeah.
Thank you, all of you. We are already short of time, and yet we have a burden of questions with us. Thank you, Dr. Rodriguez. Thank you, Dr. Rao, for joining us from that far. Thank you, Dr. Sriraman. I have pending questions for you. I'll send you an email with that. So we are expecting to send you the remaining questions as a form of email. If you can, please send us the replies. We'll share with that with our other panelists and other guests so that we can discuss and build upon that those remarks you made. Thank you for this success. I now like to request Dr. Mistry to conclude this session.
So the session is concluded, and thank you all again for your very insightful participation. Thank you. And thanks to the audience too. Meet again next year. Thanks.
Bye.
Thank
Good afternoon, everyone. This is really an incredible opportunity to talk about mental health as it relates to TB. So to begin with, we are often told that TB is a medical problem treated only within clinical frameworks. But this perspective almost always ignores all the emotional and psychological challenges that people endure at each stage of the illness. And in truth, TB shapes how you value your health and life, how you work, how you define your self-worth, how you cope, and where you ultimately place your trust in people and systems, and how you make decisions about your care. And this makes TB and mental health inextricably linked. So recently there have been initiatives to integrate mental health services into TB care. But despite this, the TB ecosystem, meaning the health systems, providers, organizations, donors, still tend to reach back to clinical frameworks. And in these cases, mental health screening tools are applied primarily to identify patients with major depressive or anxiety disorders as per clinical definitions. And these definitions are usually looked upon from the lens of the ability to function in daily life and work. And the question we really want to ask ourselves is functionality the only measure we want to use in describing psychological distress? And this is not to say that it isn't an important step forward, but it also limits the definition of mental health. And it'll only estimate that about 10% of the TB population requires any type of mental health support, and 2 to 3% require any type of specialized support. And we know this not to be the case. Part of the challenge could also be that we haven't provided the vocabulary, or even if we haven't institutionalized the vocabulary to describe the nature of a mental health challenge. And we can't measure what we can't describe, and we can't hold systems accountable for what we can't measure. And I'll give 2 brief examples from various patient illness narratives that describe the nature of a mental health challenge. The first was described as a transfer of apathy. This is where individuals narrated this experience as being, they're initially concerned about their symptoms and deteriorating health, but they did seek care across multiple providers, but they were met with apathy by external health systems. And this apathy was subsequently just internalized by the patient over time, and where they slowly began to devalue their own health and care and stopped engaging with treatment or making positive care-seeking decisions. Another example is when individuals experience this feeling that they deserve to be ill because of some actions they've done in their life. And this is often reinforced by various religious and cultural frameworks. But this type of a mental health framework is deeply harmful for both the patient's psychological and physical care. And again, this type of psychological distress causes patients to devalue their own health and life and stop engaging with treatment or any positive care-seeking decisions. So locating and addressing these types of mental health challenges is really critical, and integrating mental health support with TB care has to be treated with urgency, and it has to become synonymous with TB care because it really affects everything downstream, and not only clinical parameters, but overall quality of life. And in respect to holding systems accountable, we will need to develop a vocabulary of metrics and metrics that matter to patients with respect to their mental health. And if we can institutionalize these metrics within the National TB Program with the same rigor we've used to institutionalize clinical metrics around medication adherence or monitoring of clinical outcomes, we can really hold the entire TB system accountable for making mental health a priority. And I really look forward to new insights and discussions on how to take this forward. Thank you.
I was just another ordinary guy. I was setting my goals in life, going to college, looking after my fitness, and I was working 2 jobs, ensuring that I'm in the rat race, making sure I don't fall back in competition. I was working in one of my medical wards at that time during my internship, and I fell sick. We ran a couple of tests, and my doctor, he diagnosed me with tuberculosis. I had no idea. I mean, I was 21, physically fit. How could I get it? I couldn't believe it. So that's when the nightmare began, and my life took a complete U-turn. So I distinctly remember this time when my medicines had started, and despite that, I wasn't really getting well. And I was trying to look for ways to convince everyone around me and the doctor that we should do some more tests or do anything that it takes to come to a conclusion. And at this time, that's when he told me that I should start being a patient and stop being a doctor. The worst part is that I didn't know what I had. If it was TB, why wasn't it getting cured? I stopped feeling hungry, I couldn't eat much, felt pukey, lost a lot of weight, and it was just a matter of time before the high fever hit back again. So I pushed him for the sonography, and we did the sonography, and he checked my lung. And he said, "Sab theek lag raha hai, why are you worried? Kuch nahi hai, we'll look into it." And then he coughed and his hand slipped, and that's when I remember the other lung was infected. Now both my lungs were gone, and I was shattered. I didn't know how to take it. So that's when we decided to change the doctor, and in no time I was diagnosed as a borderline XDR patient. One of the most difficult moments of my life was telling my mom that XDR TB has a very high mortality rate, and I had to do that myself. The medicines I was taking, they were having a lot of side effects, and I developed thyroid, I partially lost my eyesight for some time, I had impaired hearing, I had jaundice. Sometimes it's funny because I can't even count the number of side effects I've had. So nobody counsels TB patients. Depression is one of the main things. I used to vent out by breaking things and weeping, something I never imagined I would do, but it was really getting tough, and there were times when I felt like ending it all.
Dear keeper of dreams, I know who you are. I know everything about you. You disguise yourself as perfection. You are the fear that does everything you can to hold me back, that begs me to be complacent. But I see through you.
If I had to fight TB, I was going to give it all I had. I started working again. I had plans, and TB would have to wait.
Because when you look at the road ahead, you see struggle, you see impossible.
It wasn't easy. It was having 2 lives. I had to carry a box of medicines everywhere I went, and bathrooms had become special places because that's the only place I could go and take my medicines and come back and live the life which no one knew about. And people think it's really difficult living with half a set of lungs and how to do that, but I was going to do the impossible. As days kept getting better, I had decided that I was going to defeat TB. And I wasn't only going to survive, but I was going to live the life that I always wanted to live.
I did the half marathon. I ran as if nothing mattered. And this year, I went a step ahead. I had decided if I finish my treatment, then I would go for one of the most challenging treks in India, Stokangi. Call it a quirk, or my way of mocking at TB is whenever I set a benchmark or achieve something which I thought I couldn't have, I always carry my X-ray with me, and once I'm done with it, I take a picture with it. And it's just a reminder that, nothing is impossible. I was lucky to have great support from my family, my friends and doctors, and that's where I got all the determination to do this. And let's fight TB and not the patient. Let's give them all the support they need. And let's end TB in India.
Hey everyone, my name is Ritu Khattar. I work as a consultant with a strategy consulting firm. Having faced tuberculosis 5 years back, and also the challenges associated with lack of patient support during my own treatment, I'm going to speak on the same topic, importance of patient support during TB treatment. So I'll cover this session in two parts. First, what are the components of patient support? Second, what steps can be taken to ensure patient support? Now, coming to point number one, what are the components? The first one is patient education. So when I say patient education, it is just not, informing the patient that, hey, you're suffering from tuberculosis and you have to consume these medicines. No, you have to inform the patient, educate them how you need to take these medicines. What is the type of diet that you need to consume? It's very important to consume a protein-rich diet, and a lot of time patients are not informed about the same. Also inform them the duration of the treatment, 6 months, 9 months, 12 months. Let's be transparent to them. And simultaneously also being transparent to them about the potential side effects of the medicine. Second component is family education. Now, whatever information you are sharing with the patient, it's also important to share the same with family members, because it helps to address the issues of gender discrimination also. Now, a lot of times what happens is that parents start feeling that nobody is going to marry their daughter because she's suffering from tuberculosis. And sometimes it also happens that they tell their daughters not to disclose this information in public. So if you want to stop all of this, it's important to educate the family members. Third, mental health support. Absolutely important. People fall into depression during treatment because it's very prolonged treatment. Even I suffered from depression when I was going through the treatment. Even post the treatment, I still face the issue of depression. So now in terms of delivery, it could either be in form of online format or there could be offline sessions. But whichever format we are choosing, we have to ensure that it is delivered in a non-judgmental and empathetic manner, because only then patients will start feeling comfortable and they will actually feel that somebody is supporting them in this journey. Fourth, financial support. Again, it could either be from the government in the form of schemes, or it could be from the employer in terms of paid leave. Fifth, it has to be inclusive, male, female, LGBTQ. Everyone's needs and challenges should be addressed during the treatment. Now, coming to the second part, what can be done to ensure patient support? First, make it a survivor-led design format, because these people have suffered through the ordeal, and hence, if they are included, it will make sure that it is holistic, practical, and empathetic. Second, government support, as I said above, could be in the form of financial or ensuring that there is a counseling staff in those centers, and just in the form of awareness campaigns as well. Third, public-private partnerships. Fourth, having this included in the medical education and training at the postgraduate level or even at the undergrad level. So I really hope that, considering that this issue of patient support is so critical, it gets addressed in a timely manner so that patients are able to recover in a speedy and efficient manner. Thank you.
A very good afternoon. Thank you so much for joining us here today. Am I audible to everybody?
Yes.
Yes, we can hear you fine, Ashna. Hi, good afternoon, everyone.
Hello.
Good afternoon. Am I audible?
Yeah.
So, Ashna, our session official time is 3:45. Are we going to be just sort of live from there?
Dr. Bhan, we can't hear you. Are you on mute?
Can you hear me now? No?
You can hear.
Hi. So sorry for the disruption. Am I audible to everybody? Very good afternoon, and thank you for joining us today on this live discussion on TB and mental health. What we're going to do here today is try and understand how TB and mental health affect each other and what lived experience the survivors are with respect to mental health challenges due to TB, and also what can the health system do and how can we deal with TB and mental health as comorbidities, what interventions are needed to provide relief to affected individuals in terms of integrating TB and mental health care. And to do this, we're combining expert opinions as well as survivor opinions. So we're drawing from clinical expertise, community research expertise, as well as lived experience to talk about these issues. We're just going to do a quick round of introductions and then we're going to dive in. So we have with us today Dr. Anant Bhan, who's a researcher in global health and bioethics and the lead for the Sangat Bhopal Hub. We also have Dr. Saurabh Mehrotra, who's a psychiatrist at Medanta Medicity. And we have Kayuri Bhanushali, who's an MDR TB survivor herself, a copywriter, and a patient advocate associated with Survivors Against TB. Finally, I'm Ashna Ashish. I'm a public health professional, a lawyer, an MDR TB survivor, and I will be moderating this session for today. So just to start, I'm going to start with you, Dr. Mehrotra. Could you just give us an idea of how TB and mental health impact each other? And the second part of this question now in light of COVID is how has COVID affected the mental health of TB affected individuals? Thank you.
Right. So tuberculosis and mental health have a bidirectional relationship. People with tuberculosis or people with a diagnosis of tuberculosis are more prone to mental health issues. And data would suggest that anywhere between 40 to 70% of people with tuberculosis do land up with a psychological or a mental health problem. Now, the reasons for this are many. Tuberculosis itself leads to, or some symptoms of tuberculosis or some symptoms of psychological problems are related to tuberculosis. The diagnosis of tuberculosis and the stigma which it brings itself leads to mental health issues or problems. Then the difficulties which individuals have to face after a diagnosis of tuberculosis at the level of the self, at the level of the family, at the level of the society, that leads to a lot of stress in individuals, and psychological problems stem from there. And we also know that a lot of side effects, psychological side effects, are related to the medications. So unfortunately, medications related to tuberculosis also have psychological side effects. And all in all, this creates a scenario where people with tuberculosis are found to have a preponderance of depression. They are found to have a preponderance of anxiety disorders, a lot of stress, a lot of fear related to it. There's a lot of uncertainty which stems into the minds of individuals. Because of this, they'll end up with sleep issues. So, host of medical problems. The chances of the chances of increase of substances as a resort to relax one's mind is also seen. So there's higher chance of substance abuse as well. And people with mental health problems are also more prone to tuberculosis. That's also something which has been, seen. So 40 to 70%, as I said. What happens is that this has a very deleterious effect, mental health issues, on treatment of tuberculosis itself. Because, for example, people who are very anxious or very depressed or feel stigmatized, or they have fears and phobias and uncertainty, they are unlikely to be as compliant. So compliance reduces over a period of time. Many of them, because of their depression and sadness, will not want to take medications, or they may even drop out of treatment or follow-up, which in turn encourages relapse and treatment resistance over a period of time. And during COVID, the problems of individuals with tuberculosis have actually increased several fold. We are looking at a situation where tuberculosis itself is not great for the immune system, and then we are looking at another disorder which another disorder where the immune system is very, very important. Everybody talks about immunity related to COVID and how we can increase our immunity. So it's like, a double impact. And my guess is we do not have any data as of now to support the claim, but psychological problems of people with tuberculosis have increased several fold as COVID has also set in the past 2 years. Treatment compliance may have been affected by this as well. And the severity of illness is also a possibility, that people with tuberculosis may have landed up with more severe COVID because of the comorbidity itself.
Thank you so much, Dr. Mehrotra. Absolutely, to understand that this is a bidirectional relationship, and also just in terms of contextualizing the impact. So now, while there are limited studies on TB and mental health, even in the Indian context, we do have studies that state that 1 out of 4 TB affected individuals are likely to be depressed. And when you look at drug-resistant TB, which is a more lethal form of TB, that's the chances of depression or anxiety are even higher. But let's go behind the numbers and really understand what is the lived experience of the people affected by tuberculosis. And for this, I'm going to go to our speaker, Kayuri Bhanushali. Kayuri, what was your experience? What mental health issues did you encounter during your TB care journey? And how did you cope with them? If you could just throw some light on that. Thank you. Kayuri, could you unmute, please? Thank you.
Okay. When I heard my diagnosis, I was really shocked, and then I was depressed, and then I went in denial that it cannot happen to me. But it was like with the help of my doctors, I was really able to manage it well. But then that's it. this is how it happens. First you cannot believe that this can happen to you, but because everywhere because there were many cases around me, but I wasn't aware, because again the people are keeping it to themselves, and we are not supposed to reveal this disease to others due to stigma. So that was the case with me. Yeah.
Thank you. Absolutely, Kiri. It's so important to talk about this, and the denial and sort of the impact of this tends to be that, how can it happen to me, or why me? And also, I can speak to this as well, and I'm sure you can relate, that the treatment itself tends to be so difficult. We both dealt with MDR-TB, and everything from the length of the treatment to particular medications that can then have mental health side effects as severe as psychotic breakdowns or suicidal tendencies. So to deal with all of that is, of course, a challenge. And given that we know this, that survivors, through survivor narratives and through whatever studies are coming out, that TB and mental health are comorbidities. Dr. Bhan, my next question is to you. Given this context, why is there a reluctance in the health system to incorporate MH services in TB care? Is this a resource constraint issue, or is this the result of taking an overly clinical approach to TB? What do you think are the factors at play there? If you could just talk about.
Sure. Thanks, Ashna. Pleasure to be on the panel, and again, very important set of conversations both yesterday and today in the summit. So, as Dr. Saurabh and Kiri were alluding to the fact that it should not be surprising to us that there is this comorbidity between TB and mental illness. If you look at the parallels, a lot of stigma, a lot of discrimination, a lot of isolation, a requirement for long-term care, chances of relapse. All of these are common across both mental health conditions and TB. And so, of course, unfortunately, we have a situation where there is a requirement, but the health system might not be geared up to be able to provide an effective response. And this partly, I would tend to think, is because our health system is often focused on a very vertical approach to programs. So you have the TB program, which is a vertical program. The mental health program also is largely run as a vertical program. If you look at the primary care system, they look at mental health in a way that, this is not our expertise. This should be handled by psychiatrists or psychologists. And of course, those specialists are in short supply. So ultimately, what that means is that the availability of mental health care becomes much more difficult. And the data, again, very clearly shows that there is a huge treatment gap for mental health care in most LMICs, including in India. So that huge treatment gap does not exist only for TB. In fact, it exists for any patient who is entering the health system. Most patients, especially with common mental disorders like depression and anxiety, are likely to be missed if they come to a frontline clinic. They might be given vitamins, they might be given painkillers, they might be also worked up for NCD screening, diabetes, hypertension, but it's highly unlikely that they will be worked up for the possibility of having a mental health condition. So this clearly tells us that there is a need to think about what we can do differently and what kind of mental health integration can we have in the system. And I think the COVID-19 pandemic certainly has reinforced the importance of mental health care in the health system. So I would tend to think that we need to think in the way our health system works. So if you look at primary care, so what could be the role of frontline health workers like ASHAs and ANMs? Our work in Sangat and many other similar organizations like the Center for Mental Health Law and Policy has shown that task sharing is possible, so that you can work with frontline health workers so that they are able to do at least basic psychosocial care. Now, the new cadre of community health officers who've been introduced as part of the comprehensive primary healthcare reforms, one of the 12 packages which is supposed to be handled by them is actually focused on mental health. So as more and more CHOs are being recruited into the health system to manage the health and wellness centers, then can we hope and expect that there will be better coverage of mental health conditions at the primary care level, and especially so for screening and for provision of psychosocial care and knowing who to refer up the system to a specialist. Secondary care, you have these district hospitals, especially where often you have a district mental health program running, you might have a psychiatrist. Then how do you optimize care in a way that they are expecting to receive these referrals and then providing care and then linking them back to community supports? Because it's one thing, just like TB, to give maybe medication for 15 days, 1 month, and then say, please come back after 15 days or 1 month for your refill, and then there is so much loss to follow. Any longer term treatment will only work when you have retention in the program, and that needs, of course, you to ensure that there is support available. And finally, in the tertiary care, you have the medical colleges, you will have large hospitals. So that is where often the specialists will be there, the large departments will be there, where inpatient facilities will be there, where research is happening, including from a public health side. So I think that's where we can expect that even at that level, we need to ensure that they're ready to receive and expect that TB patients might require mental health support. And also within the TB program, I think the providers of the TB programs, I've spoken to some state TB officers, etc., they really need sensitization. I think they recognize this as an issue, but they just don't feel equipped. So if we can work through our networks to ensure that they are sensitized, they know what to expect in a patient, which might be indicative of mental health issues, how to screen them, how to ensure that they are given resources to support themselves, their caregivers are provided support services, and then who to refer up the system to a care provider who is a specialist in mental health. If we can build all of that in, I think we'll have a more effective response in the health system to patients with TB who might also be facing mental health challenges.
Thank you, Dr. Bhan. Since you brought up health workers and task sharing, this is just a follow-up question to you. In terms of mental health personnel, we clearly have a resource crunch in India. And also with health workers, given the pandemic now, and this is something that I think even Sangath has worked on, where health workers are facing burnout. So how do we equip health workers to now approach this role of providing integrated MH support? And what can we do to sort of equip them and empower them? Because it shouldn't end up being one more thing that they then have to comply with, that they are not equipped to really facilitate or deliver. So.
Absolutely. So I think first of all, we have to recognize that there is emerging evidence, and there is enough evidence also, again, from many contexts, including India, that it is possible to work with community agents, whether those be frontline workers, but also members of the community, to train them to provide psychosocial care. And this has been shown through randomized control trials. This has been shown also in small scale-ups. So it is certainly possible to do, right? So that there is no lack of evidence to show that. You raise an important question. Does this expectation mean that they are further going to be overburdened? Because at the end of the day, every program seems to expect them to do something. And that's a fair question to ask. But what training them through task sharing approaches does also is equip them to be able to handle their own struggles with in their own personal spheres, professional spheres. If they are, for example, trained to do better counseling through these programs, then that counseling can hold them in good stead in many of the other work streams that they manage. For example, convincing a family who is reluctant to get vaccinated, convincing a family who might not want someone who's pregnant within the family to go access institutional delivery, right? Because if you're a good counselor and you're trained in that, then of course that will help you in multiple other spheres. It also helps them navigate their own mental health challenges. In some of our trainings, ASHA workers have come up to us and talked about the fact that, I faced these symptoms myself. I just did not know that I had depression, and hopefully I'll be able to deal with them. Or they talked about the fact that there is addiction in the family. Their husband is struggling with an alcohol addiction, and some of the resources which have been provided can help them in their personal sphere. Because if there is some addressing of those challenges in the personal sphere, she could also, of course, do much better in her professional career as well. So absolutely, we have to recognize the challenge, but look at how we can enable, for example, the role of digital technologies so that they can use that for support services, etc., might be relevant.
Thank you, Dr. Bhan. Dr. Mehrotra, I'm going to come to you next. When we look at communities providing support or families providing support, one of the things that would help, particularly in high burden and LMICs like India, is looking at how we can skill families to provide basic mental health, first aid or emotional support to TB affected individuals, and how we can provide skilling to TB affected individuals so that they can self-manage or identify when they need help to the extent possible. So in the context of both families and TB affected individuals, what areas do you think are relevant for skilling when it comes to managing mental health and TB concerns together?
Sorry, Ashna, I missed the last part of your question. Can you just repeat it?
Yeah, so with respect to both families of TB affected individuals and the
The
affected
voice
individuals themselves, I'm just going to put it in the chat here for
was
you.
breaking up. I missed the last part of your question.
Right. Am I audible now? Am I breaking up for everybody or? Hello?
Yeah, you are audible. We
Yes,
can
am I
hear
audible,
you.
Ashna?
Yes, Dr. Mehrotra, we can hear you. Can you hear us clearly?
Yes, I was saying I missed the last part of your question.
Right.
I missed the last part of your question. Can you just repeat it?
Which areas of skilling do we need to look at to equip both families of TB affected individuals and TB affected individuals to deal with mental health challenges in TB?
Right. Sure. So this has to happen at every level. Now, when I was doing my post graduation about 17 to 18 years back in psychiatry, I came to know that India has about 3 to 4,000 psychiatrists and 1,500 clinical psychologists. This was about 17, 18 years back, and now when we hear the numbers haven't changed much. So we still have about 3 to 4,000 psychiatrists, and we have about 1,500, psychologists. So one, there is a big resource crunch. But many years back, psychiatrists realized, and some of the professionals realized that mental health issues across, populations, people suffering from various disorders, so mental health issues cannot and should not be left to the mental health professionals alone. So every individual, whether a professional, whether the person having problems related to tuberculosis, or whether it's a healthcare worker, whether it's a family member, should be equipped with the most basic of techniques to help people with psychological or mental health disorders. Now, a lot needs to come in from the caregivers. Now, whether it is, a physician or a respiratory medicine person who is responsible for the direct treatment of individuals with tuberculosis, the person should be informed enough to pick up some mental health issues, as well as be able to rectify or help the individual with these mental health issues. Then it is the other support staff. Now it is available at different levels. There are various centers. So what we require probably is an extensive training of the people who are dealing with individuals suffering from tuberculosis. If this little training can be provided, it will actually go a long way in helping individuals with tuberculosis. On occasions, just the simple question, how are you feeling, is enough to initiate a conversation and help solve some issues. In the past 2 years, what we've seen with COVID is that, people are overwhelmed and there is a lot of stress. And what is the government saying? The government is saying, talk to each other, communicate, share your feelings. The most basic of techniques which facilitate people to vent out, which, help them problem solve. So it has to happen at every level. People have to be sensitive enough. Anybody who has anything to do with tuberculosis or otherwise has to be sensitive enough to the mental health needs, has to initiate conversations, ask the simple question, how are you doing? Right? And that itself helps. People are able to share, they are able to ventilate, they feel better, they feel making people feel supported. So the most basic of techniques help, and we cannot rely just on the psychologist or the psychiatrist to be able to do all of this. I'll give you an example. When it comes to our own MBBS training, psychiatry during internship is a very small part of the training, and for many, it may be an optional thing. So even doctors from other specialities may not be equipped enough to ask these questions related to mental health, find out if an individual is suffering from depression. And this obviously has serious consequences, because now we don't have a disorder, or we cannot have a situation where, irrespective of disorder, you don't address the mental health issues. If you have a physical ailment, you are bound to be in a state of stress, you are bound to be affected because of it, and everybody needs to ask. So from my perspective, it has to come at various levels. It has to come at the level of the doctors. Every doctor, irrespective of profession, should have a better training to deal with, understand mental health issues. Then it comes at the level of the various centers where people are, whether it is dispensing medication, they should be able to, or they should be trained to understand basic mental health issues and to be able to address them. And all of this is actually possible with some trainings. All of this is actually possible with some trainings. Unfortunately, mental health has not been the mandate of the government, so to say. Mental health has always taken a backseat. This is the first time in the recent budget we have heard that the government is focusing on mental health. So it has to come from the government. It has to be part of the TB program. Mental health issues need to be integrated with all possible TB programs. Training needs to be done at various levels. And doing this is likely to help 80 to 90% of the people who are affected by the disorder. And for the other 5 to 10%, there are referral mechanisms. There should be referral mechanisms in place, and they can be taken care of by the mental health professionals. I would go to the extent of saying that if we want to or have dreams of eradicating tuberculosis, then it cannot happen unless and until we address the mental health issues completely, alongside, of course, what we do for tuberculosis.
Thank you so much, Dr. Mehrotra. Kayuri, I'm going to circle back to you for a bit. So you mentioned in one of your coping mechanisms that your doctor sort of sensitizing you really helped. But I want to take this a little further in terms of, so of course, there's this element of support that needs to come from the health system or the family or your caregiver. But even at the individual level, there are things that affected individuals do. I mean, we did this through the course of our treatment to cope with the challenges, to the extent that we could at an individual level. And we've seen this in Survivors Against TB in the support group, where so many patients are anxious and they don't know what to do about it, and they have fear of reinfection and they're feeling depressed and dejected. What are some of the things that helped you at an individual level cope with this? For me personally, it was reading that really helped me, but I want to hear what you had going on there. Kayuri, can you unmute, please?
Actually, it is really very terrifying, because when I got ill, then there were no such peer support groups. I couldn't speak to, because the first thing that happens is when they tell you you are having TB, you get depressed there and then you don't know what to do it. So everything just instinctively came. Like, I started writing whatever thoughts were coming. I was just writing it, and after writing, I started doodling. So this thing just came to me instinctively. Like, there was nobody to tell me do this and do that. So it was really very bad time, but after I started writing, it really helped me to write more, to doodle more, and yeah, this was my way of coping my fear and everything.
Thank you so much, Kayuri. From the community standpoint, what can we do to address the mental health needs of TB affected individuals? If each of you could just mention a couple of things. I'm going to start with you, Dr. Bhan. Just a couple of things that we can do to address mental health issues that TB patients face. From a community perspective, what do you think they need?
Sure. So I think certainly one thing is awareness, right? We need to enhance awareness and help create supportive community structures. If we do that through community engagement, I think that's going to be a very good start. And even these conversations become extremely important. When we normalize conversations around mental health, when we normalize the understanding that mental health illness is not exotic in any way, it can impact any of us. And in fact, some of us might be more at risk of mental illness. That might help. I think the role of TB patients, survivors, champions is extremely important here, because if they also speak about the need for integrating mental health into TB care, then I think there is more likelihood that the TB program and the health system will listen into it. So if we advocate for that inclusion into care pathways, that would be really nice. We need to also ensure that we talk about the fact that TB care does not only, mental health care does not only need to be provided by specialists, and we can actually enable the kind of networks that you talked about. If there are support groups, if there are individuals in our network who can be provided resources for self-care. In fact, there are very good programs, including by WHO, the Self-Help Plus program, the SH Plus program, which works well at a group level. So if actually we can ensure that these kind of programs are running, we might be actually able to respond to a lot of mental health challenges which people are facing. A lot of hand-holding would help. And as both you, Ashna, and Kayuri have talked about, how you faced it, perhaps not with adequate support, but now that if you were to be speaking to a TB patient or an MDR TB patient, you might be able to actually provide them with a lot of guidance around what to expect. And at the end of the day, a lot of the stressors also come from a whole range of things. One is even navigating the challenges with testing, and that I think was disrupted in COVID-19, as I'm sure the summit has talked about. There are challenges with accessing care, with follow-up, with clinical management. And so, half of the stressors are probably related to access issues or availability issues as well, besides, of course, the stigma and discrimination. And all of that requires, of course, a community-based response. So I think, all of us as a collective can certainly play a big role.
Thank you, Dr. Bhan. Kayuri, if you could just mention one or two things that you think are critical from a TB-affected individual's point of view in terms of mental health.
I like to mention that you should spread knowledge about this TB and the medication on which people are, because there are some people who come to me and they are very much scared because their color is changing, and these are like young kids, so obviously they'll get scared. So if they have knowledge that it is a temporary phase and later everything will be back to normal, then they will be much at peace. So this patient education related to TB and its medication is very much important. And yeah, I think now that peer support is, because these patients are coming to us with their medication problem. Look, I cannot tell him what medicines are having what effect on you, because medication effects, I think, varies from people to people. So peer support is also really very important.
Thank you, Kayuri. Dr. Mehrotra, the last question is for you. As you mentioned, anxiety, mood disorders, and addiction disorders, even things like tobacco use or living with HIV. When we look at all of these things in correlation to TB and the mental health impact that comes in sort of a multi-directional way, how do we create a comprehensive model of mental health care where all of these elements get addressed? And how do we integrate that in the current system? Since we're short on time, if you could just give us a couple of things, that would be great. Thank you.
Okay. See, it has to happen at the level of the policy. There has to be a conscious decision that mental health issues are extremely relevant and extremely important in individuals with tuberculosis and across disorders, and they are part and parcel of the treatment which is provided for tuberculosis. Unless you see it as part and parcel of tuberculosis and the treatment includes all of that, it's not going to work. So it is part and parcel of the treatment. We need to equip the people who are dealing with patients with tuberculosis with information, literacy, awareness about mental health issues, and how does one tackle the common mental health issues. On occasions, there may be just simple issues of logistics, medications, some support may be required, some reassurance may be required. So equipping individuals who are dealing with people with tuberculosis is very, very important. Now, this is very important. There has to be self-help. We must use the digital technology to our advantage. Kayuri talked about the fact that she Googled a lot. Now, this is the day when a lot of applications are in place. If we can have some sort of an application, which is like a self-help application for individuals with tuberculosis, then they may find ways and means of navigating the problem better. And there need to be referral mechanisms in place. So which are the group of individuals, for example, tuberculosis and depression and smoking and alcohol use? These are the sort of patients which are best handled by mental health professionals. So we need to equip people. We need to integrate mental health services as part of management of tuberculosis. We need to have mechanisms right from self-help to referral to psychiatrists in order to deal with individuals individuals with tuberculosis.
Thank you so much, Dr. Mehrotra. We have another question coming in that is very important, so I'm just going to take some time to talk about it as well. Dr. Bhan, I want to approach you with this question. When you look at both TB and mental health, there are very high levels of stigma, both with these conditions, just independently, and of course, when they're integrated, then it's dual. How do we sort of mobilize or empower communities and affected individuals, encourage them to go seek mental health care? Because creating a comprehensive care model is one thing, but then there's also the issue of uptake of services and whether people actually go for these services. So if you could just throw some light on that. Thank you.
Sure, thanks, Ashna. So, our experience with trying to integrate NCD programs tells us that one way of doing that is just universalizing mental health screening, for example. If every adult who's coming to, say, a primary healthcare center is asked to also be screened, and there are good screening tools available such as PHQ-9. So when they're being worked up for diabetes or hypertension, then why not also for mental health conditions? When they go to a doctor, say a medical officer, then in the way Dr. Saurabh was describing, if we can ask a few leading questions to try to find out about their mental health and well-being, we might be able to identify someone who's struggling. So, we certainly need to do a lot at the system level, at the provider level, and of course, they need to be trained and supported to do that. Now, at the level of the community and especially patient survivors, it's also extremely important for them to get the support to recognize that this is something which could happen, and if they were to face any symptoms which are indicative, that they should reach out. That there is no shame, there is nothing to be stigmatized about in terms of accessing care. In fact, accessing care is something which is a normal thing to do, and if they do reach out, that they will be provided support. They should not feel that this will be another way for them to be stigmatized, that when they went into a facility, the fact that they were TB and they might not have had a positive experience, they might have this fear of reinforcement, that if I were also to go ahead and complain of struggling from a mental health perspective, but then will I have a double whammy of some kind? So of course, if we have a sensitized health system and we have our patients understanding that this is something which could happen to them, and being willing to come up to access care and get that care in time, then I think we'll have a much better situation for sure.
Thank you, Dr. Bhan. And we still have more questions coming in. So I'm going to go to Dr. Mehrotra first and then Keyuri with this. What is the impact of mental health, or what kind of mental health issues do TB-affected individuals face post-cure? So when we're looking at life after TB, Dr. Mehrotra, if you could just throw some light on, is there any residual mental health issues that affected individuals tend to face? And then Keyuri, I'm going to come to you for your experience post-cure. Thank you. Dr. Mehrotra, could you start? Can you hear us?
Okay, I thought the question was to Keyuri. Now, what we need to understand is that yes, individuals with tuberculosis are likely to face a host of mental health issues. What we most commonly see is over a period of time, anxiety developing, depression developing. Depression is actually quite common, as I mentioned. There's a lot of stress. There is uncertainty. There is fear, and even individuals who have completed the treatment of tuberculosis may continue to have psychological problems which need to be addressed. Once the problems are taken care of, we must not forget that individuals are likely to have the sequelae of treatment on many occasions. People are run down by very long treatment, especially when we are looking at treatment resistant cases. The treatment may go on for a couple of years. There may be considerable side effects. So the end of pharmacological treatment for individuals with tuberculosis is certainly not the end of care. So psychological needs will continue to exist, and people need to be supported for a very long time subsequent to that. And most importantly, they need to be integrated back into the society. Now we don't, or we shouldn't leave it at the treatment is over and that's the end of what we do. Integrating those people back into the society, getting their confidence back, trying to ensure that they are meaningfully engaged and they are meaningfully employed in their professions, looking at populations which are now there are vulnerable populations which need to be addressed separately. They may require regular counseling services. So for me, the pharmacological treatment, the medication ending as far as tuberculosis is concerned, is very a small part in the larger picture. The mental health needs still need to be addressed. The sequelae need to be addressed. There is a fear of a relapse which looms in many individuals that needs to be addressed. Vulnerable populations especially need to be counseled, and integration back into the society is very, very important.
Thank you, Dr. Malhotra. Kayuri, what was your experience? So after you were cured of TB, are there any mental health issues you faced, and what
It's
were your
like,
coping mechanisms?
yeah, it's like when you go to a gym for exercise, on the very first day we cannot do it. We develop a muscle over a period of time, and then we can do all exercise very well. The same thing is with this. While you are on treatment, definitely you have fear, you are anxious, and because it's a long treatment over a couple of years of time, you have like developed this fear and anxiety for too long. So it is not going to go away immediately after you get cured. Yeah, you will be happy that I am cured. So this is to be addressed. And one more thing I wanted to say. Yeah, relapse. What Dr. was saying, that relapse, we are always in a fear of that disease will come back, because recently it happened with me. I got a boil and I thought it is an abscess. I felt it is an abscess. So I just was so terrified with the fact, okay, I'll again get this disease. So this fear of that the disease will come back to you, it keeps on haunting. So this is what happened with me. Yeah.
Thank you so much, Kayuri. Last question for the day. Dr. Bhan, when we talk about vulnerable populations and residual mental health issues for them, how can we sensitize them or prepare them, whether it's gender minority or sexual minorities or people with certain comorbidities, whether it's diabetes or people living with HIV, or pre-existing mental health conditions. So for this particular vulnerable group of people, as Dr. Malhotra mentioned, there have to be a separate set of guidelines. In your opinion, what would that look like? What would be a couple of key elements to really give them the support they need post treatment?
Yeah, that's a good question. We over the last couple of years have been working with marginalized populations. We've started work with transgender communities. We have also started work with persons with disability. And at the end of the day, one of the major challenges is that our health system and our health facilities are not really geared up for their needs. They're not inclusive. They're not accessible often. Diversity is not something which is recognized, and that is a problem. We have a health system which is non-responsive in many ways, which often means that many of these individuals do not go to health systems. They might go to, for example, a pharmacy and say that I have X symptoms and can I get some tablets for that? Or they might go to a quack, or someone who's accessible, who at least talks to them respectfully. So there are two parts to this. One is, of course, the health system needs to look inward and try to make that reform happen. And of course, for that, we need to also work with the health system, have those conversations and make them aware what the challenges are, both in the way our health professionals are trained, but also our health facilities are designed. So just like we have baby-friendly hospitals, can we not also have trans-friendly hospitals, or can we not have hospitals which are inclusive to the needs of diversity and inclusion? And on the community side, of course, we need to do some hand-holding. Peer support becomes important, as Kayuri was talking about, providing them with the resources so that they understand these challenges, recognize them, and access care, and making that connect. So when you have a responsive health system and you have a community which understands the need to access care early, then we will be able to, again, perhaps do a better job at ensuring that the needs of those who are traditionally marginalized are much better met.
Thank you so much, Dr. Bhan. Thank you to all our speakers today. And as we can see, TB has a catastrophic impact on the mental health of affected individuals. And this affects their quality of life and also their ability to complete treatment and defeat TB. What we need is recognizing that TB and mental health are comorbidities at a programmatic level, integrating mental health care services that are suited to meet the needs of diverse populations in primary care, sensitizing various stakeholders in the process, whether it's policymakers or health workers or health providers or families or TB-affected individuals. And the most important thing for an affected individual, at least, and if you're watching this, if you're somebody affected by TB and you're facing any mental health challenges, please do speak up and reach out and seek help. There is no shame in taking care of your mind. We take care of our bodies, right? For TB, you take your medication, you make sure you have access to adequate nutrition. Taking care of your mind is just as important when you're battling something like TB. Thank you so much for joining us today. Please stay tuned for upcoming panels. Thank you to the speakers once again. Thank you all.
Thank you.
Thank you.
Thank
Thank
you.
you so much.
Thank you.
Thank you.
Hi, I'm Dipti Chavan and I'm an MDR-TB survivor. DR-TB treatment can be tough and long. When I was undergoing treatment, I realized that discussion around TB and the quality of care that is provided to patients often leave out the perspective of the patient completely. We as patients deserve high quality care. Care that we define based on our experiences, expectations and need. A few questions we could ask to ensure high quality of care could be: what is the form of TB that I have? Have I been given a DST? What are the most common side effects of the drugs that have been prescribed to me and how can I manage them? What are the adherence techniques that are available to me? What are the government and other social and economic supports that I can enroll in and how? Asking these questions will help you assess the quality of care that you are receiving and also enable you to hold the health system accountable in case you are not. High quality of care should be ensured for all the patients to make their fight against TB easier. For more information on TB, download the Talking TB app. Also write to us on our Facebook, Twitter, Insta or ShareChat.
Hello and welcome to our panel on redefining quality in TB care for equity and access at the India's TB Summit 2022. India has committed to ending TB by 2025. Yet this effort is impossible without providing high quality, reliable TB care. We often speak about access to high quality diagnosis and treatment, but rarely of care as a holistic and comprehensive topic. Even today, the fact that 50% of deaths related to TB occur despite the patients seeking early care is a shocking reminder of how poor the quality of care is. How is it acceptable that we cannot save patients from a curable disease, especially when we have the means and the tools to do so? Why is the quality of TB care suboptimal, both in the public and in the private sectors? More importantly, who is defining quality of care and for whom? To address many of these questions, I'm joined by a stellar panel Our first speaker is Divya Sojan, an MDR-TB survivor, advocate, and nurse practitioner. She will be speaking on quality of care from the patient and the community perspective. Our next speaker is Dr. Jishnu Das from Georgetown University. He is a leading thinker who has done extensive work on quality of TB care. He will be speaking on redefining and reimagining quality perspectives in TB care. Shibu Vijayan will be our next speaker. He will be speaking on the challenges of delivering high quality care in both the public and the private sectors. And finally, our closing speaker is Dr. Guy Stallworthy, who has done extensive on-ground research and work on the quality of care in the private sector. He will be speaking on how to ensure quality of care in the private sector, drawing from several country experiences, but also his work in India. So without further ado, I hand over to our first speakers and also look forward to your questions and the discussion that will follow. Thank you again for joining us.
Good morning, I'm Divya Sojan. I'm happy to be a part of India TB Summit 2022. Today I'm going to talk about my lived experience and that of many I have supported and interviewed. I'm a nurse and have had TB twice. Each time the experience was totally different. Today I'm a TB survivor than a healthcare provider as I talk about my topic, quality from patient and community perspective. What is quality? Who should define quality healthcare? Quality of care is the degree to which health services for individuals and populations increase the likelihood of the desired health outcome. What is patient-centered care? Providing care that is respectful of and responsive to individual patient preferences, needs and values, ensuring that the patient's values guide all clinical decisions. TB interferes with various facets of life, including physical, psychosocial, cultural, and economic. In tuberculosis, a positive user experience can improve retention in care, adherence to treatment, and overall confidence in the health system, leading to better health outcomes. Ensuring patient-centered care is a particular challenge for TB given the long treatment plans required for detecting and curing the condition. From community perspective, let's look into a few benchmarks of quality care in TB drawn from personal experience. High quality care should be available, accessible, and free. If a healthcare facility offers free test or treatment, but it is located miles away without convenient and affordable transportation, it is neither free nor high quality. Affected individuals and their families experience hardships in procuring drugs, availing healthcare facilities, and paying for long-term treatment. Rupees 500 is what a patient gets during TB treatment. Will 500 be sufficient for their needs if it is the breadwinner who is affected? I had to work during my treatment compromising on physical health as my leave was not sanctioned. There should be leave rules for working patients with paid leave or at least half pay. It not only gives financial stability but also aids in health recovery plus reduction in community spread and dissemination during the initial days of treatment. If the quality of care is only high in terms of its effectiveness, and not so much with respect to affordability, availability, or accessibility, then that is not the care to begin with. High quality care is best evidence-based practice. From the time a patient steps in, she should have accurate, best, and free diagnostics that adhere to the relevant WHO guidelines that necessitate the drug susceptibility testing to avoid time lapse in detecting and treating drug-resistant TB. She should have access to the best quality medicine, regardless whether she is taking treatment from a public or private sector. Efficient. Another ignored aspect of quality care is efficient, timely, and flexible care. TB affected individuals are also workers and often the only breadwinners in their home. Healthcare facilities should be open according to patients' work schedules so as not to impede their employment chances. This must be available promptly so that patients are not forced to continue taking medicines just because of the delay in test results. Digital or telephonic follow-up can actually cut off the cost and save patients time. We need to expand and strengthen a 24/7 toll-free helpline that will actually provide patients with help and information. High quality care should be safe. By safe means avoiding injuries to patients from the care that is intended to help them. With MDR treatment, many of us live with permanent disabilities. Early pickup of side effects of the drugs with close monitoring will be helpful. High quality care must be transparent and provide patients with information about the disease and treatment. Patients must be made aware of what the hidden cost of the treatment will be. Care without this information is neither free nor transparent. They also need to know all the possible side effects they can expect and how they can manage them. Patients should be provided with information as and when they ask for it in easily accessible or visual format in their local language. Privacy of the patient. Divulging a patient's TB status not only exposes them to unnecessary stigma or discrimination, but it also likely to create unwanted panic in the community. Trustworthy. By trust, I mean how many TB patients are confident in their ability to receive the most effective treatment if they are sick. How many would recommend the clinic to others with TB? How many TB patients bypass the public sector for care? And how many patients are confident about complete care and a zero relapse? High quality care on mental health. Personally, I was going through a crisis before I was diagnosed with MDR-TB. Later, during treatment, crying spells persisted. Everyone, including me, just ignored it. Building a strong emotional and psychological support system for TB patients is crucial for increasing the chances of survival. TB has been extremely medicalized, and the so-called soft areas like counseling, patient care, adherence support, nutritional support, and psychological support is seen as not so medical. A 2014 case report published in the journal BMJ presented the case of a 25-year-old male who was undergoing treatment for MDR-TB. He developed drug-induced psychosis. The victim continued to have psychiatric symptoms and committed suicide in the hospital. There is a paucity of research that explores the exact association between TB and suicide. Apart from the definitive psychological side effects of certain drugs like cyclosporin, which is used in MDR-TB, there are other drug-induced side effects which add to mental woes. There is a position where every drug-resistant TB vendor across the state should have a counselor, and how many centers does have one? What's needed is actual counseling, because they may not have a direct impact on the psychological health, but they reduce tension. This is the biggest reason that the minute the patient feels better, they do not want to go back to drugs. The lack of counseling services for TB is the biggest gap, and even the best diagnosis and treatment are not enough until and unless the patients are counseled and given the right information. Apart from the drug-induced side effects, the stigma attached to TB often causes discrimination against patients, resulting in job loss and turbulence in interpersonal relationships, being other reasons which impact mental well-being. The symptoms could be due to various reasons, including chronic nature of the disease, long and costly treatment, social stigma, and medical problems such as infertility, pain and breathlessness, and financial instability. Concerns related to mental health is vast and need to be focused for recovery in every sense. We need to create a framework that includes a package of services that addresses many of these issues. To conclude, high-quality care is people-centric and includes patient interviews and reviews of doctors for the reference and safety of other patients to protect their interests. Thank you.
Good morning and good evening to you wherever you are, and thank you for having me present to you on this important occasion of the India TB Summit 2022. My name is Jishnu Das, and I am a senior visiting fellow at the Center for Policy Research in New Delhi, as well as a professor in economics at Georgetown University, Washington, D.C., and the National Bureau of Economic Research in Cambridge, Massachusetts, USA. Let me talk to you today about the quality of care for tuberculosis. This is work we've been doing for a while now, for the last decade at least, and it's based on a very intense and productive collaboration with Professor Madhukar Pai, who's my co-PI and has been active, as you know, in tuberculosis for a long time, Benjamin Daniels, Ada Kwan, Veena Das, Ronindra Das, Vaibhav Saria, and Iser Delhi, And our partners have been the wonderful organizations of the World Health Partners in Patna and PATH in Mumbai. And funding has come from multiple sources, including the Gates Foundation. We have further resources and links to the papers that I'm going to discuss. I would especially encourage you to go to kutubproject.org and look at what we have to offer over there. Okay, without further ado, a lot of this is material that by now should be quite familiar with you, which is there are 10.4 million cases of tuberculosis worldwide estimated, with 3 million thought to be so-called missing cases. This is all pre-COVID, by the way. And India, which is here in this picture, accounts for a quarter of the world's cases and 1/3 of the missing cases. The National Strategic Plan 2012 to 2017 committed to universal access to quality TB diagnosis and treatment for all TB patients in the community, and the government aimed to eradicate TB in the country by 2025. If you want to fulfill that very noble aim, we do have to think very hard about how we're going to get there. And one key question is, are we providing the quality we need for TB patients to be diagnosed appropriately, treated, and then cured through their long journey with the disease? And one way people have been getting at this is through something called pathway studies. So what's a pathway study? A pathway study is an interview of a TB patient, of a person who has been diagnosed with tuberculosis or was diagnosed with tuberculosis in the past, and it asks them to tell us the story of how they got diagnosed. So maybe the person says, look, I had a cough, and then I went to my local chemist. I went to my local chemist, and the chemist told me, well, here are some medicines, take these medicines and come back or go to a doctor if you're not well, if not well in 5 days. After that, I wasn't feeling well, so then I went to a doctor. The doctor gave me, the doctor was an MBBS, maybe an MBBS doctor, and he told me, take some more medicines and get a chest x-ray done. Once I got the chest x-ray done, I came back to the doctor and he said, I see something here in your x-ray in the lungs, and so maybe you should go to the government hospital and get a sputum test done. So then we went to the government hospital and we got a sputum test done, and from the sputum test, it was discovered that I have tuberculosis. So that's a pathway for a patient, and there's wonderful work that's been done by S.K. Kapoor and others that shows this kind of pathway for many, 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 many patients, right? So what does this tell us? So for example, these 108 patients here, out of them, 8 started with a chemist, this one. 67 started with an informal provider, 33 started with a qualified practitioner, right? Eventually, out of these informal providers, 4 went directly to DOTS, right? 48 went to a qualified, this is this one here, 48 went to a qualified practitioner, right? So what do these pathway studies tell us? Well, these patient pathways can be long and convoluted. An average TB patient in India is diagnosed with TB after a delay of 2 months and is seen by 3 healthcare providers before diagnosis. My understanding is even this might be an underestimate. The pathway studies, nevertheless, they're wonderful, they're very informative, they're important for policy, but they're silent on what happens when patients visit doctors. So we know, for example, that these 8 people, or these 48 people, they went to qualified practitioners, but something very interesting also happens, which is some of them go on to DOTS, some of them don't, right? Within qualified practitioners, they may rotate a little bit. So we know whether they switched or not, but not why, right? Moreover, a lot of times patients may not know when their TB actually started. जो मुझे खांसी हुई थी, was that really tuberculosis or was that an allergy or was that just pollution, right? Kahan se shuru karu main, right? So what we've done is something called standardized patient studies. And what are standardized patient studies? These are commonly used in medical training. And then in 2012, I, along with my co-authors here, Alaka Hala, Veena Das, Manoj Mohanan, Diana Tabak, and Brian Chan, showed how the standardized patient method could be extended to large population-based samples. So what is this method? We interview and select people from the local community and extensively train them. Extensive training is about 20 days, 25 days sometimes, to present the same case to multiple providers. Now, because the providers don't know that these are not real patients, they actually treat them as real patients. So this allows us to understand how patients are treated, but importantly, it's not a method to try and capture wrongdoing by healthcare providers. So first of all the data are anonymized at the provider level. And then, more reasonably, providers may have multiple reasons for preferring one strategy over another, right? What this tells us is, a little bit about the provider, but it tells us what the patient experience is without telling us necessarily why it is that way, right? So we started by working with standardized patients in tuberculosis in 2015. And we showed that it had high validity, low detection, which means the doctors were not able to tell who was a real patient or who was a standardized patient. And it created meaningful variation. We could tell that some doctors were getting it, others were not. Since then, there's been a massive and rapid expansion of the use of standardized patients for tuberculosis in multiple countries. Here, for example, is our first study, then it moves on, it goes to Nairobi, Kenya. It's been done in China, it's been done in South Africa. Here's another study in China. So it's really spread all over the world. Right? Question is, what have we learned? First thing we have learned is that the quality of TB care can be very poor. So let me give you specific examples. Fewer than 5% of our patients, standardized patients, receive the correct treatment if we count the correct treatment as doing the right tests and diagnosis and not giving incorrect medicine. The numbers are much better. It's between 20 and 50% if we consider a more lenient definition that does not penalize unnecessary medication, even if it's potentially harmful. Right? What does this mean in real life? Right? So here are 765 TB SP interactions in non-MBBS facilities, right? So these are Ayush or informal providers, right? Out of these 765, 17 refer the SP. 618 do not ask for any TB testing at all. So those are all incorrect. 130 ask for some type of TB testing. So these are, correct if lenient, actually this plus this. So 130 plus 17 divided by 765 is the 17% correct if lenient. But then look what happens. 28 gives some contraindicated drug. So if we take out the harmful medications, then it drops down to 13%. 102 give no quinolones or steroids, right? 47 suggest TB, 55 do not mention TB. 40 give other unnecessary drugs, 7 give no unnecessary drugs. So if you say, how many people actually said TB, look, I'm worried you might have TB, ask for some TB testing and don't give unnecessary drugs, the answer is 7 out of 765, and that's the roughly 1%. Okay. You can say, well, how do we know this is general? How do we know this is not just Ayush, informal people? What is the generality of this finding? And it's this. The low numbers that you saw there is partly because these were not MBBS doctors, but even among MBBS providers, average quality of care has severe deficits. So let me show you these numbers a little bit. So among the non-MBBS, and this is, we are defining correct here as our lenient definition, right? It's 25% among the non-MBBS, 43% among the MBBS. So it's still less than 50%, even if non-lenient. A lot of them are doing chest x-rays, which is why they're getting this right? Microbiological testing, as we know, is low, right? Very few are referring cases. And then these are contraindicated things, actually. Fluoroquinolones and steroids are not good for somebody who has tuberculosis. Antibiotics are being used all the time. They're not as harmful as fluoroquinolones or steroids, but still, there's reason to believe that we'll be in trouble if we keep doing this. Notice one more thing. There's always been a worry that doctors are starting on TB treatment without appropriate tests. We don't find that at all. So one good part of the care that's being received is doctors don't start patients on TB treatment till they're pretty confident that they have TB. Right? You can, on this right-hand side figure, you can look at how different MBBS are from non-MBBS, and this is something that's called a forest plot. And it shows you the odds ratios. So that means a multiplication. So this says that the MBBS doctors are 2.8 times more likely to correctly manage. It's relative odds to the non-MBBS. They're more likely to do chest x-rays. They're more likely to do sputum tests. They're way more likely to do gene experts. They're less likely to refer cases. They're slightly more likely to use fluoroquinolones and less likely to use steroids. Right? Second thing, now let me show you something very, very interesting. This is the second thing. We say that the quality of care is average quality of care has deficits, but we have to be careful, because what it really says is that the average quality of care is very variable, right? So let me show you this picture, which is quite interesting. If average quality of care was very bad or low and everybody was the same, we'd expect these graphs to be all together, right? Instead, what we find is they're very spread out. Let me show you what that means. So let's take this graph, which is Mumbai MBBS. That says there's some providers, Mumbai MBBS providers, who are really not that good at all. They're less than 25% likely to get the correct treatment. But the majority of them, which is this part here, so think about this as histograms, the majority of them are actually fairly good, right? They are able to get it right between 60% and 100% of the time. Now you can see that this kind of variability is a feature of the Indian medical system. We see it for the MBBS doctors in Patna. We see it for the Mumbai MBBS doctors, where a bunch of them are not good, but some are really, really good. We see it for the Mumbai non-MBBS. There's some very, very good non-MBBS providers, even though the bulk are quite poor. And we see it among the Patna non-MBBS. Right? So the right second lesson is that the quality of care is extremely variable. Right? The third lesson is medical knowledge is not the limiting factor. This is very interesting. So in India and China, we have interviewed the same doctors we sent the standardized patients to. So what do? We have sent the standardized patient. The patient has gone and said, Doctor साहब मुझे खांसी हो रही है, पिछले 3 हफ्ते से, और मैंने दवाई भी ली थी लेकिन कुछ नहीं हो रहा, right? Now 3-4 months later, we send surveyors to the doctor and we say, Doctor, we want to know how you would treat this patient. And then this second guy starts off, डॉक्टर साहब मुझे 3 हफ्ते से खांसी हो रही है, मैंने गोली वोली ली थी, दवाई ली थी, लेकिन कुछ ठीक नहीं हो रहा. Right? It's exactly the same statement, and we ask the doctor to proceed as she would with a real patient. In this case, of course, the doctor knows that she is being observed and potentially evaluated, so she is trying to do the best that she knows. Right? Now look what happens. When we do these things, which are, by the way, these are called in health policy, these are called medical vignettes, right? These doctors get it right 81% of the time, but when we send the standardized patient, 36%. And this gap happens in every major thing. It happens for the chest x-ray, it happens for sputum testing, it happens for referrals, it happens for antibiotics in the opposite direction. They tell us they would not give it, but in practice they do. This is not India, this is China, right? In India, it's exactly the same. In every single important measure, we find that doctors tell us something different from what they do, right? So what does that, what does that mean? So, in 2008, we pointed this out in a very important paper with Jeff Hammer and Kenneth Leonard, and we said that this is something called the no-do gap. Now, this no-do gap has been demonstrated in every study since then in a wide variety of conditions and countries. These patterns are not India specific. They seem to be happening in every country. So these studies are expanding now to many countries. There are different deficits in countries and settings, but this methodology that we have developed and used allows us to understand these deficits quickly and address them in future quality improvement attempts. So let me show you. So for example, here's China. In China, nobody is doing HIV tests, even though HIV, TB are very closely related. Maybe not in China or India that much, but definitely in Africa. You'll see that a lot of people are getting medication. You'll see that chest x-rays seem to be widely used, but sputum tests are not, right? In Nairobi, in Kenya, you do see a little bit of HIV testing, which is this black here, right? But you also see that these guys tend to prefer the sputum test to the chest x-rays. In South Africa, HIV testing has become more integrated into the protocol. In Mumbai and Patna, you see that in the hospitals, they're very, very likely to do chest x-rays. They're among the best in the entire world in terms of doing chest x-rays, right? But they're much less likely to do sputum tests or gene experts, right? So you start to get a sense that yes, there are deficits, but they could be different, and we can tailor our attempts at improvement to what we see. So let me conclude. Pathway studies show that TB patients in India require multiple consultations before they're diagnosed. Standardized patient studies show why this might be so. What we find is severe deficits in average quality of care, but remember, the key story is variation. There are some doctors who are truly excellent and some who are very poor. So enormous amounts depends upon how patients are able to access the very good doctors in our system. Medical knowledge is not a limiting factor. Doctors seem to know a lot more than their clinical practice suggests. So understanding how doctors can be aided in reaching the correct diagnosis sooner is one of the biggest challenges for the TB community today. Let me end here and thank you once again for your patience and for this wonderful opportunity. And I hope a very good evening, morning, afternoon to you wherever you are. And again, please do go to www.kutubproject.org and look at our studies, look at our resources, look at our papers. And I hope that you have a wonderful rest of the day. And thank you again for this invitation. Goodbye.
I'm Dr. Shibu Vijayan. I'm the Global TB Technical Director at PATH. I'm happy to talk and present on the redefining quality in TB care and also talk about the challenges of offering quality of TB care in public and private sector in India. So the topic which I'm going to discuss today is largely on the challenges of delivering high quality TB care, both in private and public care. And as we all know, the quality of TB care must be centered on the patient perspective to ensure the needs and expectations are fulfilled. So you know that quality of TB care have different perspectives. Though the intention is to actually, as we all know, that there is a vision from the highest leader in the country to end the TB by 2025. So to that, we also need to identify the missing cases, both in public and private, and also provide high quality of TB care to the community with the preferred choice of providers. So the choice of provider, we know that is not the system-driven thing, which is actually a patient-driven thing. And we know that this quality of care have different dimensions when we look at from the perspective of the system and patient perspective, and also the provider perspective. So the system might have actually defined something, might not get translated into the right mode when it comes to the provider perspective. But essentially, it all talks about affordability and accessibility and equitability. If you would want to summarize everything into something which is common. And from a provider's perspective, it is always looking from a standpoint of curing the situation or even mitigating the existing pain or suffering of the patient. So not necessarily all the providers are targeted towards curing. So if you look at the philosophically, we know that the government of India or even TB control program is designed to have equal quality of care across public and private, and that is being articulated in the national strategic plan, and also in the standard of TB care in India. So the whole idea of standard of TB care in India is to kind of come up with this even standard across the profile of the provider. So and this figure clearly says, if you take one indicator of access to quality drug sensitivity testing and rapid diagnosis for tuberculosis, you see the disparity between public and private. You see that among the publicly notified patients, you see 26% of the patients is getting access to rapid molecular diagnostic tests versus only 11% in the private. So we know that there is a problem, and I'm going to touch upon the challenges of it. So if you look at from the challenges in delivering high quality care perspective, there are multiple factors involved in there. Is limited knowledge about where to seek the care, the provider's no-do gap, the provider's attitude about the insensitivity attitude or stigmatizing, discriminating attitude. There are financial factors which actually influence the provider's behavior. Underuse of appropriate technologies might not be like, we might think that if the government is providing services to public and private, everyone is using in the same way. There are, as I mentioned, there are different types of providers who know the standard path. So this is again coming from a study done in India by Jishnu Das and company with the standardized patient pathway study. So it's back to the evidence. So the poor quality of TB care is contributed by all these factors, both patient as well as the system level or a provider level factors. So, what we are proposing is that we are proposing a framework for addressing these challenges in delivering high quality care. This is actually, again, derived from the evidence-driven Lancet Commission paper, which covers multiple factors, which covers the redefining the service delivery part, which covers the transforming the health human workforce, igniting the purpose them, and there is talking from the patient perspective, the demand part, and also governing the entire system. So how do we govern all these things? So I'll touch upon the details of it in the subsequent slide. And also, what we are also seeing in the background is there is a lot of digital engagement could probably ease out this connecting dots and also ease out the process of executing quality of care. So if you look at this thing, you see that there is a national commitment from a governance perspective. I would want to mention that it's a national commitment to effective coverage of services, quality to be defined. So one is like we define what is that quality, which is the intention of the standard of TB care in India, which is being defined the quality, and the national strategic plan is defined. There are public health standards. The government of India defined how it need to be primary health care. Delivery standards need to be there. Integrating with the primary healthcare where the social practices are better understood. So we know that if the TB is being referred to a higher center where it's exclusively TB, that attached to a lot of stigma and it's not accessible. So that needs to be considered. Human touch. When you talk about the health human resource, there is a lot of soft skilling required before approaching TB patient, because TB patient is more of a social construct rather than a disease process. And also, how do we ignite demand? So let's listen to TB champions and advocates or educate communities and clearly give them clearly give them opportunities and create opportunities for meaningful participation rather than having one-sided approach. So there are efforts taken in this direction. In the subsequent slide, I'll be talking about that specific efforts. So one is how do we kind of improve the governing? So the launching of TB-free campaign, the PM said that the government is implementing national strategic plan to end the TB. So one is a larger emphasis on quality diagnosis, treatment, and support coming from the highest leader in the country. Then the standard of TB care, which I mentioned earlier, also been talking about irrespective of the medical paternity, where the patient sees care, there need to be quality ensured. Government of India also pursues a collaborative approach with all stakeholders. So within that framework, how do we see there are still opportunities for improvement? The standard of TB care in India needs to be revised, which probably will happen soon. We also need to measure. So it's any governance structure needs to be actually using the clear-cut metrics for measuring the quality indicators. These are some indicative indicators which mentioned here: time spent with the provider, counseling efforts, environment, whether it was private enough for the patient to open up and discuss things. If the patient would like to visit the provider again, something like that. These are just indications. So redesigning, from the redesigning service delivery, we need to actually think about addressing the comorbidities. One of the reasons for not going or not seeking care or not completing treatment is also having comorbidities, which has been addressed by differentiated TB care. And most of the TB care is actually slightly not in the primary care. How can we actually get that involved in the primary care? That is another way of looking at it. Digital applications, which is kind of a gender-sensitive digital applications. That cut across, that also kind of mitigate a lot of the gender gaps. So there are indications about all these things mentioned here, the integration with the primary health care and automated AI-powered, computer-aided X-ray software deployed in the peripheral facility, and also the digital adherence technologies. Moving on to transforming health human resource, health focus is that, again, digital human interface is required, even if the digital tools are applied with documented no-do gap measuring. So this is a good way of actually no-do gap measuring, understanding the prescription audits, and then accordingly address it. Monitor also incentives going to the patients and providers to kind of nudge the patient, provider for better behavior. Capacity building, digital communication, digital voucher payment system, also kind of assuring the timely payment to the partners. Coming to the demand from the patient side, it is expectation of the health delivery of the quality of healthcare can be a pressure and persuade between providers to deliver effective care. The patient awareness is something very important. Often patients not aware about lack of TB symptoms. The better, so one of the advances happened by the strengthen the use of TB Arogya Sati, which is a citizen app for citizen as well as for patients, and strengthen use of Nishya Sambhak, which is a call center. So these are some digital enhancements. So in summary, digital can enhance the quality of care through multiple interventions. Having said that, we should also not forget the human touch and we also need to have indicator to measure the quality of care. Thank you so much.
Thank you very much for this opportunity to share some thoughts on the future of quality TB care in the private health sector in India. I should point out that these are my own views based on observations in several countries from a long way away, but I'm not speaking here on behalf of my colleagues in the Foundation's India country office. Now, I propose to make these 5 points here. The first 4 relate to the short to medium term, but in the 5th point, I'm going to make some observations about a potential longer term future. But I think it's important to start by clarifying my premises and to remind ourselves of the problem we're trying to face here. There's often a fundamental ideological controversy about the private health sector, and I find it helpful to confront this head-on. On the one hand, there are those who believe that it's terrible and that the role of public policy should be to compete with it or minimize it as well. There are others who think it's terrific and who tend to idealize the private health sector and the role of markets. I find myself disagreeing with both extreme positions, or if you like, agreeing with both. I think that the contradiction is resolved, at least in my mind, by distinguishing between financing and provision, as indicated in this graphic on the right here. Just because something is done by private healthcare providers, it doesn't mean to say it has to be paid for by consumers. And conversely, because something is funded by government does not mean it has to be delivered by government employees. Private out-of-pocket expenditure is the worst possible way to finance healthcare. And private financing for health is to be reduced, if possible, as indicated by the direction of this arrow. This is for reasons of quality and efficiency as much as of equity. But there are strengths and weaknesses in both public and private provision, and both can deliver quality, affordable care under the right circumstances. So let's remind ourselves of what is at stake here. Private providers are the source of as much as 80% of initial early care seeking in India and elsewhere in the region. We know that the quality of private TB care is generally poor. Only a third of qualified private providers comply with even a minimal definition of correct care when a patient presents with classic TB symptoms. And we know that quality is somewhat better in public sector, although of course there's much to improve there as well. But here, non-technical quality, and by that we mean issues that patients directly perceive, such as convenience and time taken and respect and confidentiality. These aspects tend to be perceived to be better in the private health sector, which is why the population has, so to speak, voted with its feet over time. Now, Chapal Mehra and colleagues have done a great job of reminding us that quality looks different from the patient perspective. TB programs have tried for years to compete with the private sector and largely failed. India and therefore the world cannot achieve TB control without engaging massively with the private healthcare sector in partnership. And of course, India has adopted this policy since at least 2017. But the underlying causes of this problem are formidable, and we should be realistic that progress is not going to be very quick or easy. Now, the first requirement for quality TB care in the private health sector is we have to start measuring the right things. TB programs, not just in India, but everywhere, I would argue, have to move from counting cases to being concerned with and therefore monitoring the coverage of quality services. Private notifications have doubled under the current National Strategic Plan and now amount to around 25% of estimated incidents. But we suspect that many of those patients perhaps did not have TB, and even though some of them now receive cash benefit transfers, very few receive any support from the government for their diagnosis and treatment. Now, our data on this is poor. We have sketchy and incomplete publicly available data on what happens to those patients during treatment. Now, I would suggest that TB advocates should be demanding access to such data. Now, a flagship element of India's quite extraordinary strategy for engaging private providers is, of course, the contracting of intermediary organizations or PPSA. I can't overstate the significance of India's policy change in this respect. No other high-burden country, to my knowledge, has increased domestic funding so much and dedicated such a large proportion of it to supporting private patients and their providers. I believe that budgets have been approved to establish these intermediary agencies in over 400 districts, and perhaps 18 contracts are now active for well over 200 districts. But it's already clear that there are some serious problems with this model. Payments are to be based on results, so implementers need substantial reserves of cash to fund operations for up to a year or two. And NGOs do not have access to loans. This is exacerbated by late payments, which can be several months in arrears. And we know that several implementers have not been able to pay their staff for several months. This is no way to achieve good results. I know that technical support agencies have been contracted to try to improve this process, but it may be necessary to put this model on a fundamentally different basis. Some comments now about pharmacies. These are the first point of care and are extremely convenient to patients, but are underutilized by TB programs, I would argue, everywhere. We have tended to ask chemists to refer symptomatic TB patients for testing, which is not a very attractive proposition either for the chemists or for their customers. And there are two much more important things that I believe we should be doing with them. First, we can implement Schedule H1 regulations to get prescription details for every sale of anti-TB drugs. I'm aware that this is being done effectively in Kerala and parts of Madhya Pradesh and Maharashtra, but I'm not aware of how much it's being implemented elsewhere. This information should be used not just to track TB drug sales and increase notifications and identify prescribing doctors, although those things are important. But I would argue that this information should be used to reach out directly to those private patients and support them through their treatment. And secondly, we should use private pharmacies as the natural, most efficient way to deliver and pay for quality TB drugs for these patients, whether via some voucher scheme or simply by placing program drugs in private pharmacies under contract. Third point is about geographic focus. It should go without saying that India is vast and varied, and there's no single approach that can be standardized and applied everywhere. We've seen that things that can work in Kerala or Mumbai don't necessarily work so well in the north of India. UP and Bihar deserve special attention, in part because of the size, the scale of the population and of the problems there. Now, we have seen that implementers and officials grounded in those states can achieve remarkable things, including with private provider engagement. But clearly, if India is going to succeed, it must succeed in these states, and it must succeed by adapting what works elsewhere. Now, I'm aware that there are significant efforts underway and planned to make progress in all of these areas. So what does success look like in the longer term? In the long term, I don't see any good alternative to the development of a comprehensive social health insurance program, largely taxpayer funded, including both inpatient and outpatient services, and engaging huge numbers of private providers. In advanced health systems, there are three changes that happen. First of all, of course, they spend much more on healthcare as they become wealthy. But second, the proportion of private and public expenditure becomes reversed. Private out-of-pocket expenditure that represents 63% of the total in India is only 33% in Korea and 13% in Germany, for example. And a third change is equally important, as indicated in the graphic at the top. The private healthcare sector is dominant in those countries as well, but they get most of their funding from publicly controlled social health insurance. People get quality services wherever they seek care, not because those providers have better knowledge or are more altruistic, or even because the regulations say so, but ultimately because those providers have to provide appropriate care in order to stay in business. Now, I'm aware that in India, the National Health Authority and others have been thinking about this for some time, and I well remember visiting a pilot project that was testing outpatient primary care benefits in the private sector under RSBY 10 years ago in Odisha. Now, such reforms do take a long time, but I think it's important that as they are being formulated, that the TB program should be involved to make sure that the systems will benefit TB. And there's much to learn here from the experience of some of the neighboring countries that have made many mistakes that can be learned from. The vision for private TB care was well stated in this WHO document from 2018. Within 10 years, there should be full alignment of TB services with primary care seeking behavior of the population. And what would that mean in practice? At some point early in care seeking or even at home, a sample would be taken for testing. If TB is confirmed, the right drugs will either be delivered to the patient's home or else she will collect them from a convenient local pharmacy at no or minimal cost. The patient will also receive social and medical support until successful cure through some combination of digital technologies and also human interaction. Technical and non-technical quality will be combined. All of this will be verifiable using publicly available digital data systems. And in sum, every Indian will have a right to quality TB services wherever they seek care. I thank you for your attention and I look forward to the discussion.
Thank you for joining us for this panel. I want to thank all the speakers for speaking so eloquently on the issues of quality in TB care. From this panel, we have identified numerous challenges from the patient and the community perspective. These are critical because these are the end users and their perceptions of quality and definitions of quality are particularly important. There are also numerous challenges that have been identified from the health system level, and these plague us both in the public and the private sector. In the public sector, these challenges are particularly critical because the public sector is an important resource for vulnerable and poor populations. In the private sector, too, we noted several significant problems in quality of TB care. These are also particularly relevant in the Indian context because the private sector still continues to treat close to 50% of all the estimated TB cases in the country. These challenges, as you note, are not just around procedures or diagnosis and treatment, but also issues of patient support, mental health, adherence. All of these are critical issues in quality of care. Finally, the country examples provide us with very useful templates to consider that can be used in high burden but low resource countries like India. How well these apply to India and how relevant these can be when scaled up remains to be seen. I think overall we are confronted with the broader question of whether we can reverse or even contain India's TB epidemic if we do not address the issue of quality care in every sector and for every identified TB affected individuals. With these words, let me welcome you to the live discussion. We look forward to your questions and queries and hope to resolve them to the best of our knowledge. Thank you again. Good evening, good afternoon, and good evening to many of you who are in different parts of the world. I hope you can hear me. Yes. Thank you. Thank you. Thank you to all of you for joining us in this discussion. Our fourth panel, unfortunately, won't be able to make it, but I'm really grateful to Guy, who has got up at what is clearly an unearthly hour to be here with us. And this has been a fascinating panel because we've heard from end users, Divya, who is herself a medical practitioner, Shibu, who has formerly been a medical practitioner and has been involved in quality discussions around both public and private sector for a very long time, and Guy, who has been spearheading many of these, not just in India, but elsewhere over several decades. So I'm going to jump right in because we already have a few questions, and we've also many questions have emerged from the presentations that were made. Some of these presentations were, of course, related because this looks at a broader conversation around quality of care from multiple perspectives. But I want you to bring in Divya first, because I think, Divya, you have the distinction, if you can hear me, of being both a twice MDR-TB survivor and a nurse practitioner. And you faced issues of quality even in, as far as I remember, even in a city like Delhi, having access to the best public health care, right? And eventually it was in Kerala, found good quality care. So I want to ask you, do the criticism often is that patients do they understand quality of care? And how do we make these stakeholders in this paradigm of improving quality of care, especially outside of scenarios?
Good evening to everyone. Thank you for making me a part of this very elaborative, knowledgeable session. As a nurse practitioner, even though I have studied and I had worked with TB patients, but having TB and being a patient was entirely a different scenario that I had gone through, not once, thrice. But the quality of care, when I got into the same situation the third time, I personally felt what quality is. I deserve something more as a patient. That's the third time I felt, actually. But today I feel most of the patients know what quality is, what they should, what they deserve, and what they are getting. They are at many a times they are questioning the quality of care that they are getting. But as you rightly said, in Delhi, I had a very bad experience to start with the MDR treatment. And especially being alone when you are diagnosed with something bad, actually, I would say, having relapse again and again, and going through it all alone was even the memories of it's still haunting me. So even though it was even I basically reached out to the best institutes of the country, where there is actually efficient, transparent care, and being a professional of the institute, I thought I would be getting something better. Then many a times I thought, actually, if I am getting like this, what the normal patient would be getting. So that was the situation. And having a patient as a patient-centered care, of course, it will enhance the paradigm, or it will help the system to actually get into the best standard care. That's what I feel, because the patient is the even I'm a healthcare provider, plus I have gone through a patient, being a patient. So now I know better what the patient expects and how I should deliver it. So the patient is the best person to explain, to define care, the quality of care, what a patient needs. So patient has to be the center of care, I believe. Thank you, Chapa.
Thank you, Divya. Guy, if I can just take this to you, if you can hear me, Guy. Shibu alluded to this as well about community-led paradigms of quality of care in his presentation. And you have worked on improving quality of care in the private sector in particular for a long time. Now we know that in India, 1 in 2 cases are diagnosed and often treated, for TB at least, in the private sector. How do we look at this as an issue that we can? What are the key challenges, top 3 challenges, for instance, in quality of care that we need to address urgently? If we look at, for instance, the private sector.
Thank you, Chapel. also for the honor of being on this panel. That's a really tough question. I think that the way you've structured this panel points to some of the key issues we need to bear in mind. First, the experience that Divya so eloquently expresses, and that Shibu and Jishnu touched on as well, somehow that needs to be brought to the fore and focused on much more. Somehow the patient perspective needs to come through much more clearly, and it's very hard to see how to do that. But certainly having TB survivors, patient voices always present whenever healthcare is discussed and somehow brought to the forefront of the minds of healthcare workers and healthcare administrators. We can't do enough of that. We just need to find more and more ways to do it. I think it has to be backed up with systematic approaches to ensure accountability for quality of care. It's not enough just to try to say to people, this is what you should be doing, this is what care looks like. We need to put in place the systems that make quality of care not a choice, but just natural. And to my mind, one of the key issues in that is data, as I alluded to. Somehow, and there are experiences in India and elsewhere around the world where the patient perspective is captured by using technology and put to the forefront exit interviews and ranking systems and so on, so that healthcare workers are reminded about what they're doing. And healthcare workers, of course, are human, but they're working under extreme stress. And so they need to be in a management environment that helps them to deliver the care that really they know they should be doing. But then finally, I think we have to tackle the issue. I think Jishnu put it well. It's not just about knowing what quality of care is for the healthcare providers. We have to surround them with all the incentives to do the right thing. And those incentives have to do with management and motivation and so on. But ultimately, in a mixed healthcare system, they also have to include how care is paid for. If we really have to reform the way the care is paid for. Private out-of-pocket expenditure is the worst possible way to pay for quality care. Nobody can give quality care when that's how the care is financed. And so we have to figure out public policy, and ultimately it's a political economy shift to have care funded from public sources ultimately. I think those would be the three main things I would point to.
I have a question, a related question for Shibu on this, but I first wanted to quickly follow up on this because you've made a very valuable point, which is very, very important in LMICs like India. You're talking about who pays for the care, because everybody asks for high quality care. But who pays for it? Because that is the moot question. So I'm going to take that question to Shibu. But before that, I want to ask you for a minute or two to respond to this guy, because you mentioned the issue of social insurance. You mentioned RBY. And you also believe that private healthcare should be paid for by public money, in a sense. You think that is the way to go forward with improving quality?
I've come to believe, as somebody who's worked on how to improve quality in the private healthcare sector, as you said, for too long, longer than I care to remember. And as Jishnu said, we always work on, oh well, let's train them, let's orient them, let's sensitize the private sector about what they should be doing, and you can make some progress with training and education and giving them leaflets for their patients and all these things. But ultimately, there's a limit to how far you can go. And when I've asked myself the question, well, where in the world do we see this done well? Where does it seem to work well? And it does seem to be in places in which the private healthcare providers are paid from a public source, and all the incentives are there for them to do the right thing. And I don't believe we've seen any alternative where the private healthcare providers are paid out of pocket or even from private health insurance. It's really, really hard to establish those incentives systematically across the board. Always there will be good individuals, but we're talking about how can it be systematic across the board on a country as large as India.
Thanks, Kai. Shibu, I want to take this question to you because you did pioneering work in the initial years for the PPI scheme in a very challenging setting such as Mumbai, which is a very mixed healthcare setting. The environment is very challenging. Guy has been talking about the public paying for that quality of care, the public funds. What was your experience there? What were the challenges that you think were faced? Because as many people say, if you can succeed in an environment like Mumbai, you can succeed in numerous suburban environments. What would be something that you think are the top quality challenges and how they should be addressed?
Yes, thanks. I think Guy alluded to the most of the stuff of it, but I would want to mention that how we kind of figured out to mitigate the out-of-pocket expenditures. There are two critical key drivers for the patient the expenditure. It is diagnosis and the drugs. So these two were main provision through a voucher system, and that is actually prevailing in the larger scale-up version also. But what we could not address was the consultation charges, because that also kind of add on to the cost of the patient, and also the referral mechanisms to ensure quality. Like if say in classical Indian setting, we go and seek care from an informal provider in urban setting, or even a much more GP setting, and then eventually there is a cascade of referral, which also comes with the cascade of cost component, that is where I think that we need to work on. I mean, I'm slightly optimistic in that way. I think we have provisions of service delivery options, quality service delivery, service options, like going from the government to the private, or even like sourcing it from the private. That is pretty much figured out. I am not arguing that it is efficiently implemented. That's an implementation flow, which actually the government need to bump up their capacity or even willingness for that matter to actually open up that market to the private. That is, we have models and methods and tools and IT systems. Everything is being settled. Now we need to efficiently work on it. On the provider incentive part, again, there is a mechanism now. We figured out how to pay for the providers. If we target, if we notify, if we follow up on certain tasks. And I would say that could be slightly kind of enlarged into, and we need to look up whether that could be a method for paying the doctors, for delivering quality of care. So whether that can be done, open up for all the providers, or should be restricted to a certain number of providers. So that comes with an accreditation process. Probably now that the private sector engagement has been enlarged, we've been there for the scaled up provision where this is the fourth year, I would say. Pretty much we know that the level of quality at a town level or city level, who are the major drivers of it, who can be aligned to this. So there are negotiation. We know whom we need to be targeted to be talking and to be figuring out this thing. Can we kind of manage the traffic to a certain number of providers rather than actually kind of opening up to everyone, and use this digital tools of payment tools to kind of look up how we can finance and mitigate this thing. Ideal situation is an insurance where everyone will get it. But again, at least when the patient is on the diagnostic pathway, can we kind of settle it? We don't have much option for actually kind of from a presumptive case level, the payment mechanism is kind of going to be tough, unless otherwise it is that services of X-rays, and X-ray is also available now under the voucher scheme. But again, prior to that, it is very difficult. On that point, on empowering that patient, again, I would want to pivot on few things, and as partners, we also need to work together on Arogya Sati thing, which is an opportunity. I think we should not lose that, and also the Nikshay Sampark. These are opportunities to kind of capture the patient views and also engage the patient with make them understand these services are available. These are the touch points or quality service delivery points. So once we identify that quality service delivery both in private and public, that's also an opportunity to kind of give them that visibility into that. Currently, it is all public centric, but we need to open up that for the private as well. So that, I mean, I stop there. I mean, my optimism is actually kind of looking at the way that we evolved. More than, I mean, personally, I expected in this space when we actually witnessed the Mumbai thing, how chaotic it was. So I think the genuine effort from the public is something which more important than the private. If you have the openness and the right mind to kind of engage with the private, there is a chance for kind of improving that quality.
No, thanks, Shibu. These are very, very valuable points. And actually, you've very easily led me into my next question, which is directed to Guy, and then, of course, later to Divya also. Guy, Shibu referred to a whole set of issues. I also alluded to intermediaries that exist in the healthcare system, right? Our assumption often is that quality of care is only at the point of the doctor or the health provider, which is a mistake, because you mentioned the role of pharmacies and pharmacists as actually being critical points and not having been harnessed properly. Shibu also mentioned about challenges of scaling up in payments in the private sector engagement thing. I wanted you to reflect a little bit on that, about the role of pharmacists and other such intermediaries, especially in further geographies, right? Everybody who gets TB is certainly not in Delhi, Mumbai, Bangalore. So what is their role there in improving quality of care? Because we as a health system seem to be obsessed with qualified medical practitioners only. And is that a lapse on our part?
I think it is, and I think Jishnu in his talk was alluding to why we need to why we need to remember where the patient is going, what the patient pathways are. And when we do that, we very quickly realize that even if ultimately more than 50% of TB patients get TB treatment in a public facility or maybe with a specialist, that's not where they started. They started their pathway to care the way what do people do when they're not feeling well? They'll go to a nearby chemist or pharmacy to buy some syrup or something, or they might consult an informal provider or a less than fully qualified provider, especially throughout rural India, where there aren't so many qualified providers. And if they are there, they're more expensive. And so people will go to somebody familiar who's less expensive. And I think it's clear now that what people do quite naturally is they'll try something easy and nearby and cheap. And only if they don't get better, then they will escalate naturally. So I think, and with something like TB, we know very well that ultimately, if we're going to make progress, we have to move the quality services closer to where the patient starts. Otherwise, we lose too much time. We lose months. And in that time, the patient has become sicker and the patient has infected other people. So that's why it's so critical to think, where are people going first? And how can we get quality services to them sooner rather than later? And it's not easy by any means, because of course it's so much easier to work with a limited number of higher level providers. The smaller the higher volume, smaller number of higher volume providers, the easier it is for our task. But there are ways in which people have figured out how to do it, how to engage with huge numbers of providers early on in people's care seeking. And the principles are fairly similar. As Jishnu alluded to, sometimes there's knowledge that needs to be dealt with, but much more often it goes beyond knowledge into the making it easier for those people to do the right thing or to do what the patient needs them to do in order to have quality care. And that involves data systems, as Shibu alluded. Fortunately, these days we have digital technologies that can help us reach out to tens of thousands, or across India, hundreds of thousands of providers, rather than a few dozen or a few hundred, who are the places people end up in late in their care seeking pathway. So I think that's why it's absolutely critical, and arguably where we have to make some more progress in figuring out what are the models that will work across rural Bihar and UP, and with pharmacies even in urban areas.
Thank you, Guy. There is another question that I've found in my work with survivors in TB affected communities, is the question of trust. Because we do not seem to think of patients as consumers who are actively making choices, and patients choose. I found this very interesting case in Mumbai, which I often refer to, which is that the patient was simultaneously being diagnosed and treated by two of Mumbai's top doctors, because they found one's bedside manner not suitable. So even though they had the access, they were getting each other, two of the country's top doctors cross-check each other's prescriptions in a sense. And it is interesting. It was an interesting case for me, because I realized that even with a disease like XDR-TB, patients were making choices. They were making choices of landing up in two different hospitals, paying twice the amount, but also if they didn't have trust. So turning to that question, Divya, I want to bring you in, because you're also a health provider. What is the role of the trust in the system? And very briefly, if you could allude to that, and also of patient rights and information, because very often we create paradigms of quality which don't always include those.
Thank you, Chapel, for that question. Trust, it's a big term when we are diagnosed with something. Actually, it's often said, until and unless I trust my provider, maybe the doctor or whoever providing me care, if the patient doesn't trust the person who is providing the care, ultimately we are not going to get fine. So trust is such a big term. And when I was diagnosed second time with TB, I didn't trust the diagnosis. I jumped to a second consultant to get it finalized. I'm having relapse of TB. When it came to third, having a diagnosis in Delhi with MDR TB, when I went to Kerala again, I insisted the doctors to cross-check that I was having TB. So trust is something when we are diagnosed with such a disease for a long term, we have to be on treatment, and that with all the side effects, which actually as a patient I didn't want to continue my treatment. Even if I was dying, it was okay, because the side effects were such bad. So first thing, the patient should, as a healthcare provider, I should make sure that my patient has the full trust on the treatment that is being provided to the patient, so that especially in a disease like TB, it's a long run treatment. So many as these two-day sessions, everything has been covered, but still the patient goes through a lot of mental stress, financial stress, then side effects of the drugs, so many things the patient has to go through. So even if at one situation, if the patient fails, the patient of course will feel I should drop the treatment. So trust is something that has to be initiated at from the first step the patient steps into a healthcare system. And human rights, every human right like equality, non-discrimination, participation, autonomy, all these human rights fit into the quality of care of tuberculosis, because at each human right is very, very, very important in TB treatment. So looking into in every aspect of it, it could be finance, stakeholders, policies, everything. But ultimately, if it is not helping the patient, or if it is not helping the community to overcome a disease which is being run in the whole world with millions of years, and still we are not able to take care of it, we are not having a excellent drug or a vaccination, like Dr. Udwadia said yesterday, we don't have a good vaccine. Even still, we are fighting to have a good vaccine. As a healthcare provider, I always feel bad. I am giving care to a patient, and ultimately, I am getting sick, or my colleagues, they fall sick. When we are sick, they treat, even though they know it, they treat they discriminate us as a patient, or stigma among the healthcare professionals are still there. So there are so many things that has to be taken care of when we say about TB. So human rights in every aspect has to be taken care, especially in tuberculosis management. Thank you.
Thank you, Divya. I mean, I've totally run out of time, but I did want to take what Divya said to both Shibu and Guy for a minute. Just quick responses to you, because the truth is that in a country like India and many other high burden TB countries, this is a balancing act in quality of care, isn't it? Balancing patient expectations and trust, and building patient trust, to quality of diagnosis and treatment, patient support, patient education, and then of course managing of rights. But in a health system which is already stretched, and a health workforce which is often exhausted, as we saw in COVID, so just very quickly, quick reactions from both of you before I close. How do we do this balancing act? Is it even possible? Guy, do you want to go first? And then I'll ask Shibu.
I'll go first. I think it's an enormous challenge. I think one thing to remember is there's no country in the world that's solved it. It's not a problem that goes away in any health system, because health systems are always trying to improve, and they're always trying to correct the problems they face. I can only say that I think that India is on the right course, is trying to do the right things. At least in TB, it's trying to pay the private providers to do the right thing, get the drugs and the diagnosis to the patient, even if the patient is seeking care in the private healthcare sector. Many countries have not taken that policy step. And so I really have to stress how significant the mindset of the government in healthcare in getting it right, to at least trying to do the right thing. And then it's just a question, as Shibu said, of doing it better and better on a greater scale, more systematically, year on, year out. And you can't do that unless you're really challenging yourself with the right data. That's why I think that the transparency of the data in India is going to be a driver of progress. When eloquent and powerful advocates can look at the data on quality of care by state and district from a patient perspective and hold the government to account, then I think that's when progress will happen.
Yeah, so I mean, thanks, Guy, for emphasizing on that. I would also kind of pivot my conversation on that. So one is we have opportunities of interacting with the patients, and now we have this, applications, digital applications. We could start from that to, kind of define indicators of quality of care from the patient, perspective, and started doing it. And the other tool is the subnational certification for TB elimination, which is happening now based on just denominator and then other factors. I think probably that could be an opportunity for the survivors and the TB patient and citizen to come back and say, hey, where are these indicators of quality of care in the subnational certification? How weightage you're providing for that quality of care or the patient perceived quality, or how do you align with that? So I think that these are two steps we probably could actually use as tools to kind of mainstream or enter into the quality of care conversations in a much more objective way of measuring it. Thank you.
Thank you so much, Shibu. I think we've got a very interesting set of points to work with from this conversation and this discussion, and none of those are linear. There are questions of intermediaries and questions around who pays for quality. There is also the question of what is the role of communities and how communities must participate in it. But I think one of the key determinants has been what is the role of data, both on either side of this conversation. Data to empower communities to seek a certain kind of quality, but also for the system to hold both public and private partners responsible. So thank you so much for joining me for this conversation, especially to Guy, who's woken up, like I said early on, at an unearthly hour to join us, and to Divya and to Shibu. And over to the next session. Thank you so much. Thank you.
Bye-bye.
Thank you. Bye-bye.
I'm speaking to you today as a public representative, but also as an Indian affected by TB. As the third wave of COVID-19 subsides in India, TB has been forgotten. Let's not forget that TB, though curable, remains India's severest health crisis after COVID-19. It affects 2.8 million Indians and kills over 1,200 Indians every day. We urgently need to do something for our people together. COVID has disrupted lives globally and across India. People are fatigued and the economy is impacted, and everyday life is hobbling back. However, its impact on TB, tuberculosis, is probably the most significant. During India's crippling first and second wave, TB services were badly disrupted as India's health system struggled to cope with COVID-19. TB services were affected, leading to delays in treatment, in diagnosis, access, and increased suffering and problems for those affected. TB has been often missed or misdiagnosed in this pandemic. Those diagnosed often could not access treatment. Where treatment was available, there was lack of support. In many cases, the ability to manage side effects was devastating. In the public sector, an already overburdened staff often struggle to deal with the increasing demands of TB patients. In the private sector, the symptoms were missed in the hurry of diagnosis of COVID-19. However, how do we move forward from here? For starters, we need to renew focus on TB. Words are not enough. We need concrete action. We need political will and action. And we need to invest in TB. The current plans of TB need to be revisited in light of the pandemic. For starters, existing delivery approaches need to be adapted in the context of the pandemic. Patients give up treatment midway, as some cannot even afford it. Others struggle with the side effects. And we need to ensure that we trace every patient, provide them with free, high-quality treatment that is reached to their doorstep. The need for bringing in remote support and communication is really urgent. We must provide patients with information and educate them in their local languages so that people can manage their treatment, can understand what it entails and what are the challenges they need to face. It is amazing that TB, even though is curable, we are not able to manage it. There should be no one dying because of TB. If managed well, we can save millions of lives. Expecting poor patients to continue treatment without providing economic support, especially in this economy, is counterproductive. The Nikshay Poshan Yojana, though well-intentioned scheme, still faces gaps in implementation, and its amount of support is merely 500 rupees, which remains completely inadequate. As COVID-19 devastates the formal economy, the need for economic support to TB affected who find it so difficult to work is urgent. Stigma and misfortune, unless actively addressed, can lead to loss of family, employment, and even lead to discrimination and abuse. Those affected often hide their status and leave treatment midway due to stigma. For decades in India, TB has destroyed lives and pushed millions into poverty and debt. Hence, political and for financial commitment for a renewed focus on TB is critical. The COVID-19 crisis is a wake-up call, but also an opportunity to improve access to TB services. Let's not squander it.
Namaskar. I am Suvanand Sahu from Stop TB Partnership, speaking to you from Geneva. As you know, globally we are not on track to end TB. After the UN high-level meeting in 2018, there was great momentum gained. However, in 2020, the COVID pandemic set back the TB response globally by several years. Access to TB care and prevention declined, and as a result, WHO estimated that deaths due to TB increased in 2020, reversing a more than a decade-old trend of declining deaths. In 2021, recovery did happen, but it is not yet complete. Despite the setback, it is possible to end TB as planned globally and also in India. Modeling that was done for the global plan to end TB 2023 to 2030, which is under development, shows that it is possible to end TB globally by 2030. But for this to happen, increased investments will be required on not only diagnosis and treatment of all people with TB, but diagnosis needs to happen early before transmission happens to others, including at what we call the subclinical stage. And we need to prevent TB by scaling up TB preventive therapy and other means, and also finally a new and effective TB vaccine needs to be implemented. Going forward, India is very well placed to end TB in India and also inspire other high burden countries to do so. A few years ago, there was a paradigm shift in India's TB response when the Prime Minister articulated a vision of ending TB ahead of the global target. As a result, there was a new plan, efforts to end TB intensified. Going forward, I suggest 5 actions on how India can be a global leader in ending TB. Number 1, rejuvenate the political momentum in India against TB with the Prime Minister, the Chief Ministers, mayors, parliamentarians, members of state assemblies and panchayats leading in the fight against TB, with full participation of the civil society and people affected by TB and also the media. Second, increase the resources, the budget further for TB. Budget has increased in the past, which was very good, but now going forward, it has to increase, and we estimate it has to be substantially increased to be able to end TB in India. And budget should come not only from the national level, it has to increase at the state level, district level, cities budget and village level budget commitments. The third point I wanted to make is implement the learnings from the COVID pandemic. There were great learnings in India and globally as well. How to test at scale, contact tracing, infection control, digital tools use, faster research, faster licensing of researched health products are some of the examples. Number 4 is invest in community-based and community-led responses for care and prevention, as well as monitoring of the TB response. In this context, also address stigma and discrimination and turn the TB response to a rights-based response. Finally, my 5th point is take the opportunity to lead globally. There are particularly 3 opportunities that India has currently. 3 great opportunities. Number 1, the Honorable Health Minister of India is the chair of the Stop TB Partnership. This is a huge opportunity. Number 2, the G20 leadership in 2023 will be with India. And number 3 is the UN high-level meeting in TB planned in 2023 is another great opportunity. India is home to 1 in 4 people with TB. So progress in India is a driver of global progress. India can end TB ahead of the world. Let us make it happen. Thank you. Namaskar.
Distinguished participants, partners, ladies and gentlemen, I would like to convey greetings from our leadership, WHO Director General, Dr. Tedros Adhanom Ghebreyesus, and on behalf of the World Health Organization. It's an honor to address you virtually today at this special India TB Summit. This is a crucial time for the world and for the fight against TB. We are at a crossroads. While 66 million lives were saved due to TB prevention and care since the year 2000, the COVID-19 pandemic has reversed years of progress in the fight against TB. For the first time in over a decade, WHO is reporting an increase in tuberculosis deaths. Tuberculosis is the world's 2nd top infectious killer after COVID-19, claiming close to 4,100 lives a day. 1.5 million people died from TB in 2020, almost double the number who died of HIV/AIDS. It is the leading killer of people with HIV and a major contributor of antimicrobial resistant related deaths. Current global situation with conflict and crises in different parts of the world, such as those we're seeing in Eastern Europe, Africa, and the Middle East, makes it even more important that we reach individuals, communities, and populations hardest hit to alleviate the suffering they're facing. India is among the countries bearing the highest burden of TB, but in the same time, making huge efforts in tackling the disease, including during the COVID-19 crisis. We are impressed by the leadership in the country, starting from His Excellency Prime Minister Narendra Modi and the Honorable Health Minister Mansukh Mandavia. The Prime Minister's TB-Free India campaign has been critical to enable and accelerate a multi-sectoral response by bringing all ministries, all sectors, and civil society together to end TB in the country. We greatly commend the leadership of TB survivors and civil society in India through organizations like Survivors Against TB and others. We also commend the prioritization of essential TB services during COVID-19 pandemic and the use of innovations such as the Nikshay platform, direct benefit transfer for patients, and other digital and innovative technologies. This is aligned with WHO multi-sectoral accountability framework and has been showcased as a model for other countries to follow. I would like to raise an urgent call for action on 4 fronts to ensure that commitments made to end TB will be achieved. First, it is important to prioritize the implementation of top 10 priority recommendations outlined in the 2020 progress report on TB issued by the United Nations Secretary General Antonio Guterres and developed with WHO support. These include high-level multi-sectoral actions to urgently reduce TB death, increasing funding, advancing universal health coverage for TB prevention and care, addressing drug-resistant TB, ensuring essential TB services are safeguarded in the context of COVID-19 and other emerging threats, advancing technological breakthroughs and rapid uptake of innovations, enhancing engagement of civil society, communities, and people affected by TB, and of course, based on human rights and promoting human rights. Essential TB services should be sustained during the COVID-19 pandemic. People-centered delivery of TB prevention, diagnosis, treatment, and care services, including through digital technologies, should be ensured in tandem with the COVID-19 response. Tackling health inequities is vital to ensure health for all. The COVID-19 pandemic has drawn attention to the deep disparities that persist between and within countries, some of which are being exacerbated and risk widening even further. People with TB are among the most marginalized and vulnerable, facing barriers in accessing care. WHO is calling for global action to address health inequities for people with TB and other diseases. Next, we need to double investments from domestic and international sources in the TB response and in TB research and innovations, as well as concerted actions across the health sectors and others to address the social, environmental, and economic determinants of TB, such as poverty, undernutrition, and its consequences. Every has a role to play in ending TB. Individuals, communities, businesses, governments, societies. We need your close engagement and support as preparations begin for the second UN high-level meeting on TB, which was mandated for 2023 as part of the political declaration of the 2018 UN high-level meeting and the 2020 progress report of the UN Secretary General. This will be an important landmark to bolster political leadership, to help us fast-track our efforts in an integrated and sustainable way. WHO has been tasked with supporting the Office of the UN Secretary General to prepare a comprehensive review with the heads of states and governments at the 2023 high-level meeting on TB, informed by the upcoming global TB reports and the global, regional, and national high-level reviews. I wish you a successful summit and look forward to hearing back on your important deliberations. This year's World TB Day slogan is "Invest to End TB, Save Lives." We should invest our time, joint efforts, energy, and resources to end suffering and death of people, to end TB. WHO will stand by every country, partner, society, or person that decides that TB, COVID, or any disease has no place in its future. It's time to end TB.
Good evening, friends, experts, doctors, nurses, civil society representatives, TB survivors, advocates, and delegates. A wise saying goes, a journey well begun is work half done. Over the last 2 days, hundreds of us have participated with great commitment in this summit, and in doing so, begun on our journey to a new TB and health agenda for India and possibly the world. We have debated and discussed the key challenges, the burning issues, the emerging innovations, and the possible solutions for the way forward. Earlier today, the mother of a 14-year-old suffering from MDR-TB reached out to us. Her concern that her child's TB was becoming virtually untreatable because she was stuck in a small town and the doctors were unwilling to see her child due to the fear of infection and possibly stigma. As we responded to her to provide her support, I thought, this has to change. This must change. During the day, a patient advocate also reached out to me. She told me that watching TB survivors lead and design the discussions in the summit provided her with renewed hope and determination in her fight against TB. Both these stories resonated with me, and I'm sure they do with you as well. At one end was a mother fighting to save her child from a treatable disease, and at another was a person filled with hope. This dichotomy, this divide is our reality. And from this divide, we have to choose hope, optimism, and strength. Because today we have come together with hope and optimism. In a world where we are staring at conflict, fighting a pandemic, surviving economic meltdowns, and persistent and numerous health challenges. But here we are, despite our grueling schedules and multiple commitments, determined to fight and defeat TB. This conference has been an extremely successful one. With inputs from each of you, a new agenda for TB and health has begun to take shape. It is one in which TB-affected individuals and communities are taking center stage. There is so much to be hopeful about. We have discussed issues that never get discussed, from gaps in diagnosis and treatment to the need for patient support, the need for integrating mental health in TB care, and the promise of new innovations that will help us fight TB more effectively. We understand that we need an interrelated, comprehensive, inclusive approach. At this conference, we have broken down walls where doctors, nurses, advocates, and patients have come together and discussed and spoken of issues and new approaches to fight and treat TB. I want to take a moment to recognize the conference academic committee that guided us and the conference team, without whom none of this would have been possible. Please join me in recognizing their work. Finally, I applaud each one of you. You took time to engage with this conference, asked questions, made observations. Your commitment and engagement are why we will defeat and bring a world free of TB. Thank you for your support, and we hope to see you again next year. Dhanyavad.